If I could have everybody's attention, please. We're going to go ahead and get this program started. Can you guys hear me? How's this working? Is that better? And this one?
I think that's on.
That's now, it's on. Okay. We're going to go ahead and get our program started today. Thank you all very much for coming. My name is Beth Mitchell, and I'm the president of the Sebastian River Area Chamber of Commerce. And today you all are here for the Opioid Crisis Summit. I have just a few housekeeping items, and then we're going to go ahead and get started. You may or may not have noticed, but the city has installed some absolutely spectacular carpeting. So they're asking that we have no food or drinks in the room. We will have refreshments at break. Those are being provided by Indian River Medical Society and the Substance Abuse Council. So also bathrooms for anybody that's never been in this facility before are out the doors and in the lobby. I would ask everybody to please turn your phones off out of courtesy to our speakers. And wanted to let you know that there are a number of resources that are on the back table for you to take home with you. This session is being videotaped, and all of the resources and the video will be uploaded to the Sebastian Chamber website for future reference in case you need to go back and revisit some of the information you may learn here today. Having said that, I'd like to bring to the podium the chair of the Chamber's Health and Wellness Committee, Ms. Teresa Toll. Teresa is the owner and pharmacist for Bay Street Pharmacy. She's been involved for a very long time in Chamber leadership, and we're really happy to have her here today. She will be moderating the afternoon. So please help me welcome Teresa Toll.
Thank you, Beth, and thank you all for being here this afternoon. It's exciting to see this turnout from our community. I just wanted to give you a little background on the Health and Wellness Committee. We started in February of 2017 as part of the Chamber, and it was a group of people from our community who are involved in health and wellness who came to the table and joined us. And our mission statement became to inform, educate, and promote healthcare issues among Chamber members. As we started talking about what we would want to do, it became really clear late last year that this topic today needed to be a focus of our committee. The governor had labeled it a public health emergency. Our own sheriff had stated that it was an epidemic in our community. So we decided to put together this opioid summit. And we've been really working on this since the whole entire year, since the beginning of this year. Our goal is to tell the story of addiction, but we also want to provide hope of recovery, and that's why we have indeed put together these resources that Beth referenced that are on the back table, and you'll hear a lot about that throughout all the speakers this afternoon. I definitely want to thank our speakers in advance for the time that they've put in and their energy to be here today. We also hope that the attendees, will leave with information that'll help you perhaps even be able to be plugged into organizations in our community and perhaps even volunteer in these areas. I want to definitely thank Beth Mitchell, the president of the Chamber, for her idea of forming the Healthcare Committee and then all the support that she and her staff have done to bring this to fruition. Also, in your program today, you'll see the Healthcare Committee members on the left-hand side. So we have representatives from the VNA, the Mental Health Collaborative, Treasure Coast Community Health, the Plan B Laughing Lady, Substance Awareness Center, Indian River Medical Society. So you'll hear from many of them, but I just want to make sure that you know that they participated. And in addition, many of them have materials on the back table, so we encourage you to take as much as you want today. I also brought some folders that have some sticky notes in them and some pens. It occurred to me that we might want something to take notes on, so please help yourself to that as well. So with that being said, I think that, I definitely want to mention our sponsors too. I know Beth just did, but thank you. This wouldn't have happened without our sponsors, so we appreciate them as well. So with that, I think I would like to kick off today's program and invite Bob McPartland, who is our City Council member, and he's also representing today his day job, which is he's Community Development Administrator for DCF Circuit 19. Bob?
Oh, thank you. Now, I hope, Teresa, you're going to give me a little flag when it's time for me to stop talking. You know, that's the problem when you go first. You have no idea. Okay, again, I'm Bob McPartland. I guess my day job is the Community Development Administrator for the Department of Children and Families. Everybody always hears about the department. It's never a good thing, you know, but we do a very difficult job. And, you know, this opioid crisis, this is something that has been hitting Florida for the last 10 years or more, and now it's getting a little bit worse because once they started controlling the pills, people were turning to heroin and also fentanyl, which is people are just making that, and it's just like putting poison inside your body. And for the department, we receive almost 300,000 child abuse reports each and every year. And about 70% of those are because of substance abuse by parents or caregivers in the home. And then to break it down a little further is I'm for Circuit 19, which is the Treasure Coast and Okeechobee counties. We receive roughly 6,000 child abuse reports every year. And Indian River County gets about 12 to 1,300 child abuse reports each and every year. So they get over roughly 100 abuse reports every year. Like I said, 70% of those are due to substance misuse in the home, and domestic violence is a close second. And usually the domestic violence is a result of the substance abuse that's going on in the home. I started my career in 2001 with the department in Brevard County, and we investigate abuse, neglect, and threatened harm. And when I started in 2001, it seemed the big thing that was out there was crack cocaine, and cocaine was the big drug of choice. But then over the years, 3 or 4 years, then the pills started coming out. You know, I didn't know why. You know, it used to be you go to the dentist, you got a toothache, they tell you just suck it up, take some Advil. But then they started prescribing opiates for a toothache. And so I wound up, a lot of these parents that were former crack cocaine users and cocaine abusers, all of a sudden they went to the doctor and said, I had a car accident, I got back pain. Next thing you knew, they were on opiates and benzos, you know, the Xanax, and they take them in conjunction. And the concern is when you have to care for a child, especially a small child, and you're hooked on these pills, I mean, it puts those children at such great risk. And one of the big things we're finding too is we got a lot of babies that are born positive for opiates. And I don't know if anybody's ever been to a neonatal unit and you got to see a baby that basically is crying and clenching their fists for 23 hours a day. And then the 1 hour, they finally pass out and fall asleep. And then once that hour's up, then they're constantly crying and shaking for another 23 hours. It's absolutely heartbreaking. So in those instances, you know, we might, if there's not an appropriate caregiver or another parent in the home, we have to remove those children. And it used to be about a year ago, we would average usually about, for the 4-county area, removing 35 children every month. And I mean, our goal is always to place with relatives or a family friend. But of course, they have to pass a background check. And unfortunately, with the opioids, it seems the whole family is kind of devastated. So sometimes there's not another parent that's available. I mean, you can read in the paper every day. We just had in Sebastian, once you see somebody 37 years old, they die and cancer's not mentioned, you can kind of pretty much think it came down to an overdose that they died. And we had a mother who died and basically orphaned 3 children because the father was in prison. And I remember the detective, he had gone to the hospital, Sebastian River Hospital, on a Sunday. And he told me, Bob, They went there. He said they had 7 overdoses at Sebastian River Medical Center. I would have never guessed that they had 7 overdoses in a month, let alone on a Sunday. And they were scrambling for the Narcan to see what they could kind of do. So unfortunately, we have a lot of grandparents that are raising their grandkids. And you know, sometimes also what happens with the opioids is kind of like mental illness. Some families try to keep it inside and keep it a secret. And they'll enable, you know, the son or the daughter, you know, they're stealing from them. They don't want to let other people know. You know, I get calls a lot of times from grandparents, you know, because there's nothing that can be done. And they're like, they're taking care of this grandchild, so the child's safe. And then the parent will come back and say, well, Mom, I need $20 for this. If you don't give me the $20, I'm going to take the child. And they never have any idea of taking the child. They just want the $20 to get their next high, which is extremely unfortunate. And we're seeing plenty of this going on. As far as children that grow up in homes where there's opioid use. Now remember, we only respond to cases that we get a report on. There's a lot of stuff going on out there that we have no idea about. And so for children, especially ages 0 to 3, that are being raised in homes where opiates are being used, one is sometimes they crawl around the floor and they can get their hands on a pill and overdose themselves. A lot of times those parents, they nod off after they get their fix, and you could have a baby just sitting in a crib in a soiled diaper for hours at a time, which is unfortunate. The other thing that happens is sometimes they'll just leave them in front of the TV while they get high. Again, developmentally, that hurts children's development. You know, the first 2 years are very formative years. I mean, if they're not held, bathed, changed, I mean, it puts them way back as far as, you know, we have a lot of initiatives in this county, you know, getting reading levels up. A lot of those kids are going into school and they're way behind. I mean, they don't have the skills and they typically then fall behind. A lot of children that grow up in homes where there's addiction, unfortunately, they wind up becoming addicts themselves. If you have older children in the home, I guess the term is they become parentified. They actually try and take care of their parents, think that it's okay. And like I said, most of the people in this room, you know somebody who's got an opioid problem, or you've had it touched personally either by a loved one or maybe yourself. I mean, there's a lot of hope out there. I have 2 older children. Their mother was a pill user. I try to keep it all in, try to take care of it, try to manage it, control it. Sometimes there's no control of that. Until finally, as one therapist told me, and she explained it to the kids because they were having a difficult time when their mother left, and it's like they get stuck in the bubble gum. And if you try and help them out of the bubble gum, you just wind up getting stuck in the bubble gum. So they have to get themselves out of the bubble gum and to help themselves and lead a better life. But there's a lot of resources in the community that are available. Like I said, one of the ones is the Department of Children and Family. We also have the substance abuse mental health portion. We're looking at, they've been kind of successful down in Palm Beach with peer counselors. So if someone shows up at the hospital and they overdose, they put them right in touch with the peer counselor. And typically those are recovering addicts who can kind of, you know, help them along the way. Because most of the time the people don't want help right away. I mean, that's another scary thing. You would think for the normal person, if you had your children removed from you, you would crawl over broken glass to do whatever you needed to do to get your children back. But unfortunately, these parents, they got a lot, you know, they say you got to hit a bottom. They're not even on the rooftop yet. They got about 30 more floors that they got to go below. I've seen parents then go see their kids for 6 months at a time. I mean, my kids you remove, I might let them go for the weekend, but eventually I'd want to see them. You know, but I mean, it's an unfortunate thing, and especially for these children, because they'll have parents that drop out of sight. And then the children grow up and they don't know, why doesn't mommy want to see me? Why doesn't daddy want to come see me? And they have a lot of issues that are lifelong issues. So everybody, there was pen and paper in the back, because I know there's a lot of people that have questions. My cell phone number is 772-708-2900. You have to leave me a message because I don't answer any hot numbers, especially on a Friday afternoon. That seems to be when there's a lot of crises that happen along the way. But there's a lot of great speakers here that'll talk about all the different aspects of the opioids. But my focus is the children. A lot of people forget about the children. And also, because they always ask me out that I'm also out for needs, we are in need of more foster homes in our community. We have some children that are placed as far away as Jacksonville and Fort Myers. And see, because we have a lot of children getting removed, we can't place with relatives or friends, we have a need for more foster homes. Or if you want interest in becoming a guardian ad litem, which is an advocate for a child, feel free to give me a call because we're in need of those, as well as mentors for youth, be it anywhere, big brother, big sisters, anywhere. We're in desperate need of more volunteers. So I'm glad you're out here. Enjoy the afternoon. Hope I didn't go over my time, Teresa. All right?
Bob, thank you for helping paint the picture of some of the things that we don't see in the community. And again, that's one of the reasons why we wanted to do this summit. As the committee met, it was pretty clear that many people had been touched by this. And I think this is somewhat silent. I think a lot of us deal with this and don't talk about it. So it's great to hear, not great to hear the statistics, but it's good to know the information. And so the first part of our program today is understanding the problem. So we're going to have several speakers who are going to help lay that out for us. And then after we do the break, then we're going to talk a lot about the solutions that are available in this community as well. So our next speaker is Dr. Liana Erfer. She is a psychiatrist, board certified, and she is going to explain to us the physiology of opioid addiction. Dr. Erfer practices in Vero Beach. Thank you very much for being here with us today.
Good afternoon. As I was introduced, my name is Liana Erfer. I'm a psychiatrist in Vero Beach, where I've practiced for about 15 years now. I'm also a member of the Substance Awareness Center, and so I have some professional, personal, and community awareness of the opioid crisis. So as was described, I'm supposed to explain the physiology of opioid addiction, which is a big task. So I thought I'd break it down into 3 sections. Number 1, what are opioids? Number 2, how do they affect our brain and our body? And number 3, how do we become addicted to opioids? So firstly, opioids are any medication that binds to the opioid receptors. By definition, that's what they are. We have opioid receptors in our tissues, peripherally. We have them in our spinal cord and our brain. And opioids are probably the most potent painkiller known to science. So it's this combination of pain relief that's very desirable, paired with a pleasure or reward or reinforcement aspect that comes from opioid medication. So you pair the pain relief and the pleasure reward, and you get a very desirable and very potentially addictive substance. And addiction to opioids or abuse of opioids has been known for centuries. Way back when in the, it was like 3,400 BC, way back when, 3,000, 4,000 BC, the opium poppy, which is where opioids are derived, was called the joy plant. And this is not the first time in the United States that there's been an opioid crisis. There's been many chapters of history where you see opioids kind of rise and become an epidemic and then subside. One particularly discrete and meaningful opioid crisis in the United States was back in the Civil War, when morphine, which is an opioid, was used on the battlefield for medicine, for surgical purposes, but then soldiers became quite widespread addiction occurred, and they called it the soldier's disease as a result of that. So we're here to talk about the current opioid addiction. So let's talk about opioids in 2 categories. There's the exogenous opioids. Exogenous means comes from outside the body, and there are endogenous opioids. Those are the opioids that we find naturally occurring in our body. Exogenous opioids are the ones that we're going to be focused on most because they're obviously the ones you can abuse. So exogenous opioids would include some natural occurring substances like opium, morphine, what was the third one that I was going to talk about? Codeine, which is widely recognized as a cough suppressant, but is actually a naturally occurring opioid. Then there's a second category, that's the semi-synthetic opioids. Those are the the medications that are derived from plant compounds, but they've been partially manufactured, obviously, in a lab. And those are the ones that are probably the most widely recognized: hydrocodone, oxycodone, heroin, oxymorphone. Those are medical medication names a lot of people have familiarity with, and then mostly with their trade names. So that would be like Percocet, Vicodin, those substances. Then the third category are the full synthetic opioids. And in that category is methadone, buprenorphine, fentanyl, which of course is getting a lot of attention lately because of how potent and lethal it can be. So all those medications are types of opioids. They have different potencies, they have different half-lives, and it's that difference between potency and half-life that can have implications in how they're used medically, but also how likely they are to become abused. Endogenous opioids are the naturally occurring ones. So most people recognize endorphins as a term, the kind of runner's high term, and that is a naturally occurring opioid. Endorphin is, and so is enkephalin. And both of those substances are produced by the brain. They produce not only pain relief, but they also produce a pleasure sensation. So I think it's helpful to know that opioids occur naturally, but then of course when they're produced and brought in externally, you don't have much regulation over what necessarily happens. So let's talk about, secondly, how opioids affect our bodies and our brains. As I said before, all opioids bind to the opioid receptors, and they produce reactions at the different tissue levels. So tissue, periphery, spinal cord, brain. There are different opioid receptors. There's mu, kappa, gamma. I'm going to focus mostly on mu because that is the opioid receptor that we know the most about, and it's the one that seems to be the most implicated in addiction and actual pain relief and medical use. So let's look at the runner's high. How does the runner's high occur? A person who likes to run goes out for a run. Maybe they start to experience some muscle pain, joint stiffness. Maybe they even start to have some injury that they're re-experiencing from an old injury. As that pain sensation is sent up the spinal cord, up the pain pathways to the brain will release on its own endorphin. And endorphin will suppress that pain signal. So the runner will actually notice that they're not in as much pain after a period of time, which if you think about it is kind of counterintuitive. You'd think the more you're out there running, the more that pain might persist. But in fact, people that do run regularly notice that the pain is relieved. But there's a secondary effect, which is the reward and pleasure aspect of endorphin. So once that opioid receptor is bound, the pain signal is reduced, but then there is a second chemical effect. And the opioid receptor will block another important receptor in the brain. So I'm going to try to just talk about 3 details and not get too overly complicated here. But the opioid receptor also blocks the GABA receptor. And I like to think of the GABA receptor as kind of the policing force of dopamine in the brain. Dopamine is the chemical that most of us have some familiarity with. It produces pleasure, creates a sense of reward. It's important in reinforcement and very important in addiction and repetitive kind of obsessive behaviors. So when opioids bind to the receptor, they block the GABA receptor, and it can no longer police dopamine. And so because of that, dopamine can freely occupy the synapse and the brain space and the spinal cord and the peripheral tissues. And that dopamine influx is a very rewarding, pleasurable experience. So that's what the runner's high most likely results from. It's that secondary effect of the opioid, or in this case, we're talking about endorphin. So you can imagine how that is a very pleasurable, naturally occurring sensation. If we move to the exogenous opioids, those are obviously the ones that are produced outside the body. So let's imagine our runner has unfortunately injured themselves. This is not just a little injury. Let's say a runner with a broken leg goes to seek medical treatment. They're likely, or previously, they would have been likely to be prescribed an opioid medication, let's say Percocet. So that's oxycodone and Tylenol. When that Percocet is taken into the bloodstream, it still binds to the opioid receptors. It still produces that same pain suppression, which is great. If you have a broken leg, you want pain suppression. But that secondary effect of blocking GABA and allowing dopamine to flow so freely, that can be highly, highly magnified. So you get the pain relief, which is great, but then you get this second reinforcing pleasure reward circuit that gets turned on. And that's much more exaggerated than what you would get from your own natural opioid system, your natural endorphins. let's talk about some of the other physiologic effects that occur. It's not just pain relief and that pleasure experience. When people take opioids, they'll have other physical responses. Their respiratory rate will decrease a little bit. Their pupils will constrict somewhat or reduce somewhat. They'll have often like a dry mouth or maybe dry, itchy skin. They can have GI effects like nausea, vomiting. With more extended use, they'll have constipation often. They can have a cough-suppressing effect. Over time, there can be hormonal effects. Men who use opioids for a chronic period of time will often have a reduction in their testosterone, for example. So there's all these other physical symptoms that occur that are in addition to the pain relief and the pleasure response. So as is often said, no two people are exactly alike, no two brains are exactly alike, no two bodies are exactly alike, and that accounts for the differences in how different people respond to opioids, both the endogenous and the exogenous. So some people don't get a runner's high. Some people say, I don't know what you're talking about, I run, I exercise, I've never felt that. Other people say it's obvious, they've always felt it, it's why they love to go out and run, even when they're in some discomfort. From a scientific standpoint, our brains have different receptor densities and different receptor locations. So you've got, the mu receptor we talked about, the GABA receptor, the dopamine receptor, and everyone's brain has different sensitivities, locations, and densities of those receptors. So we know that that's one of the reasons that accounts for the differences why one person might be more prone to respond or to abuse opioids. We also know some other risk factors. Bob kind of alluded to some of the family and the social risk factors. People that come from a background where there is opioid abuse or substance abuse in the household are at much higher risk. People that have had a history of addiction themselves are at a much higher risk. People that have a history of mood disorders tend to be at a much higher risk, and that has been an area of a lot of research lately. Some people say, I don't just get pain relief, physical pain relief when I take an opioid, I get emotional pain relief. I feel, as if the depression that I've been suffering from has lifted somewhat. There's also some really repeatable and interesting data about people who are depressed don't get as much pain relief when they take an opioid. So a person with depression might get a dose of Percocet, and a person without depression gets the same dose. The person with depression will say that was like maybe a 2%, 3% improvement in my pain. The person without depression will say my pain's almost gone. So that discrepancy seems to have something to do with brain response to opiates. So let's just imagine there's runner A and runner B, and they both had injuries, and they're both, seeing their doctor, they're getting prescribed some pain medication. Runner A, the one that gets the runner's high, he may get his dose of like post-surgical morphine and feel no pain, feel very calm, maybe even feel somewhat euphoric and say, I'm definitely gonna take my next dose of morphine, that's working great. Runner B, who doesn't get a runner's high, may get the same dose of morphine for the same injury and feel kind of restless, maybe their skin itchy, maybe they get nauseous, maybe they vomit, and they're likely gonna say, no thanks, I don't really want any more of that, or I have something else, or I'll just manage with Tylenol. So you can see that those two differences, just in how the chemistry of the brain's response to opioid could really put one person on a track towards abuse or wanting more, and the other person probably wouldn't go that direction. But all people, regardless of those details, over time, if they take opioids for an extended period of time, they'll develop tolerance and withdrawal. And it's tolerance and withdrawal that we think is the foundation for dependency or for addiction. So let's talk about those two things, getting into the third topic, which is how do we get addicted to opioids. So tolerance is essentially just the phenomenon that we know where people who are taking a substance, it could be opioids, it could be alcohol, it could be Xanax, over time, they need to take more of it to get the same effect. So someone who started off taking their Percocet 10 milligrams 3 times a day, a few months later, they're like, I'm having to take a little bit extra, a little more than the doctor prescribed. That's not necessarily because they want to, it's because they're not getting as much of an effect to get that same pain relief or that same pleasure effect. Some people are taking opiates for pain relief, some people are taking it, I guess you could say recreationally, I don't think that's a good term, but they're taking it for non-prescribed reasons. They're taking it for the pleasure experience that they're getting. We don't really know why tolerance occurs. The brain's pretty clever. It probably, over time, wants to go back to where it was before and reduces the sensitivity to the opiates or reduces the number of opiate receptors that are available. But for whatever the reason, it happens to all people. The second phenomenon that I wanted to talk about is withdrawal. And withdrawal is simply that when the opioid medication or the natural opiate removes itself from the receptor gets, gets a little bit agitated, it gets a little bit angry. It recognizes that effect that was just present has been lost, and that can create this cascade of physical effects. And in opiate addiction, the withdrawal is particularly profound and particularly rapid and particularly brutal. So we believe in terms of addiction medicine that it's the withdrawal that really feeds addiction, not so much the desire for pain relief or the desire for pleasurable sensation. It's the desire to avoid the brutal physical effects of withdrawal. So let's talk about the physical effects of withdrawal. There are some really kind of stereotyped depictions of opioid withdrawal, but I can tell you from what I've been told firsthand, even though opioid withdrawal is never lethal, many people have said that they wished it was lethal because they just felt so miserable, felt like they were dying in the process. So some of the classic physical symptoms that you'll see as a person starts to go through withdrawal, as their blood level starts to reduce and their opiates receptors start to recognize they're no longer getting those signals. Cold sweats, restlessness, diarrhea, vomiting, insomnia, goose flesh, watery eyes, watery nose, and then probably the two most profound effects are a real increase in pain. So not just the pain that they may have originally sought opiates for, but bone aches, abdominal cramping, a muscle stiffness, just as if every cell in the person's body was screaming out with pain. And then the secondary, most, I think, significant withdrawal symptom is people will say that whatever that mood elevation or that pleasure response that they had, it's like that crashes right down. So if they felt euphoria, they're now feeling what we call dysphoria, the reversal of euphoria. They're feeling very, very frustrated, very agitated, and maybe very emotional, maybe very depressed. Just think of any kind of negative emotion that you might think of as an adjective that seems to be a possible outcome of withdrawal. So this sensation of being so miserable is sometimes called dope sick. People will say that it was the hardest thing they ever did to go through, just an acute cold turkey withdrawal. And the success rates of people trying to do that are, of course, very low because it's so uncomfortable. So I think it's really, if I could have one key point today, it would be that key point, that the avoidance of withdrawal seems to be what drives the use, not really the seeking of pain relief or the seeking of pleasure. So just go back to our runner, the runner A, the one that starts to become tolerant to the pain medications that they were originally prescribed. You can imagine that over time, they're probably going to use their prescription more rapidly than it was prescribed. They may go to other doctors to obtain more pain medications, and that's referred to often as the doctor shopping phenomenon. Ultimately, it's not uncommon for people just to start to find non-prescribed options, illegal sources to get more opiates, because over time, as their tolerance is building, they're requiring more and more. With the desire to find a larger supply and a cheaper supply, people will go to drugs that are more dangerous, or potentially contaminated. I think the fentanyl crisis, illustrates that. Often people had no intention of ever taking fentanyl, but it was something that was mixed in with whatever substance they thought they were taking as an opioid. The other thing that happens is people go from taking pills, which is how most people start, to trying to get a more quick absorption. So they'll go to smoking or snorting or using their opioids intravenously. And of course, once you get into intravenous use, you're introducing a whole new host of risks. Anytime you inject something, you have the risk of HIV, hepatitis, other blood-borne infections, just infection in general, and then a real rapid escalation of the tolerance and withdrawal cycle. The risk of overdose, once you get into these more rapidly absorbed ways of accessing the opioid effect, increases dramatically. People that are in the midst of an overingestion or an overdose of opioids will have some telltale signs. They'll have slurred speech, they'll have loss of motor coordination, they'll be sluggish, they may be hard to arouse. It's the slowing of the breathing rate and the respiratory depression that ultimately can result in coma and death. When opioid use is paired with other central nervous system depressants, like Bob referred to, like Xanax or alcohol, these things are often paired together. The risk of a lethal overdose increases, many times over. So I guess just to kind of recap, if you think of opioid addiction from a physiologic standpoint as this really powerful reinforcement cycle, you have positive reinforcement of wanting pain relief and wanting that sensation of pleasure if you get it. And then you have the negative reinforcement loop of wanting to avoid withdrawal and doing pretty much anything you can imagine a person would to avoid that level of physical discomfort. That powerful pairing of reinforcement actually results in structural brain changes. There's finally some decent amount of funding going into research as to what happens permanently to opioid addict brains, and they're getting to have a better understanding of what those changes look like. The challenge of recovery is really, really high for opioid dependent individuals. I just found a source the other day when I was researching for this, that the average United States opioid addict will go through 4 to 5 treatment attempts, that's inpatient or outpatient, over the course of 8 years as an average time effort to get 1 full year of sobriety. So you think of all those resources and all that time just to amount to 1 year of being able to be free of it, it kind of shows you, what we're up against. So, thanks.
Thank you, Dr. Urfer. You did a great job of taking an extremely difficult topic and boiling it down so it makes some sense to us about how it works. We did not allow time for question and answer, and we apologize for that, but just with the schedule today, we didn't feel that we could. I don't know if some of the speakers are going to stay around through break, so hopefully if you have questions, you can speak to the speakers afterwards. If not, I do have my business cards on the table in the back, so you're welcome to send me questions and I can forward them on and get you some answers after the program. Just wanted to make sure you knew that. So our next speaker is Dr. Harold Cordner. He's from Florida Pain Management Associates here in Sebastian. He's board certified in anesthesiology and pain management. And Dr. Cordner is going to talk to us about pain and medical treatment, kind of give us a little bit of the history of kind of how we got here. So he actually has a PowerPoint presentation he's going to be doing. Thank you, Dr. Cordner.
Thank you, Teresa. We'll get the PowerPoint up there. So Teresa originally had asked me to talk about pain and medical treatment, and then said, well, I also want to talk to you, have him talk about the whole crisis and how this started and the background and where we're going. And I've been kind of integrally involved in this for many, many years, both from a legislative aspect, pain management aspect, a physician, as well as with law enforcement. So again, thank you to the Opioid Summit for inviting me to speak. This is about a 3-hour lecture, so I'm going to do this in 15 to 20 minutes, so like this kid here, hang on for dear life, because we're going to go really fast through a lot of material, okay? So the problem. Talk about epidemiology of overdose deaths. So what I say is, we talk about this opioid epidemic and this opioid crisis, but I think we have 2 crises here. One is the opioid abuse, but also chronic pain. And if you look at that second thing, I am a doctor in a little tiny town of Sebastian, and every single day I see probably close to 10 new patients a day with chronic pain. And if you look at the statistics up there, it's about 100 million people have been estimated to have chronic pain. That's 1/3 of the United States, okay? And then you look at opioid abuse, which is skyrocketing. Everybody in this room, give me a show of hands of how many people either know somebody that has chronic pain or has a substance abuse problem. Raise your hand. That's way more than 1/3. It's almost the entire room. Okay, and so those 2 things are what brought us here. We have both the chronic pain issue as well as the opioid issue. And if you look at, this chronic pain an issue, if you look at the suicide risk has doubled. So people with chronic pain are killing themselves because the pain is so bad. And this is probably why we're in the bad situation we're in. So what is pain management? So basically, simply put, I'm a pain physician, so what I do when people come in is we say, all right, back pain to me is a symptom. It is not a disease. What is it in your back? So we want to treat the cause, and you have to make a diagnosis, right? So that's kind of what we do as pain physicians. I love this one because people think pain management is opioid prescribing. So we'll have patients come in and go, well, my doctor sent me here for pain management. Where's my oxycodone? So well, that's not what we do here. So that's not what it is. But we do invasive therapies and non-invasive therapies, depending, and they can range from anything from simple physical therapy all the way up to putting spinal cord stimulators in people. But I kind of look at this as a continuum where you want to start with simple things. Some people, they just need physical therapy or some bracing or an injection, or they've had 16 back surgeries and need something more invasive than that. So we kind of start with more conservative things, but opioids come in at some point in time if it's appropriate and they failed more conservative treatments. So if you look at kind of this Venn diagram, we have to worry about safety. We have to worry about safety for the patient. We have to worry about the abuse potential if you're going to prescribe opioids, and efficacy. And if you combine all those things, ideally that's what good practice of medicine or pain management is. But the scales of opioid therapy have tipped, okay? We started off in the 1990s where they said, well, you're undertreating pain, these people are all suffering, you need to treat them, and that became the fifth vital sign for hospitals to redress. And so they said, okay, well, we need to give these people more medications. Now the scales have tipped, and now we're restricting opioids, okay? And so we have this balance that keeps going back and forth, and we're going to talk about that a lot today. So as a physician, what is my obligation to treating pain and worrying about opioids? Well, we have to worry about that because we're prescribing them. So we have to treat the pain appropriately, adequately. We need to screen the patients. Are they at risk for abuse? Have they had multiple drug possession charges? Have they had alcoholism themselves? We have to screen those patients. And there's risk management. So we have to assess the risk in those patients as well as for the community and for those things. So for pain management, that risk management includes giving access, appropriate access to care, whether that's a procedure or medications, but minimalizing the risk for non-medical use of those opioids. So part of what every single physician that does prescribing for pain management, they have to do all these things. And these are required sometimes legislatively, some by the Board of Medicine. So you have to know your laws, both federal as well as local. You have to document medical necessity for every single patient, every single time you write a prescription. You have to have controlled substance agreements. So they're a contract with the patient where you address the risks of opioid use and that they will use them as prescribed, they won't distribute them, et cetera. You have to identify those high-risk patients. You have screening tools that you have to use to do that. You have to make sure that nobody alters your prescriptions or they're sent electronically. There's compliance monitoring where you have to do background checks, pill counts, script forgery protection, urine drug testing. Every single time a prescription is written, you have to check the prescription drug monitoring program to see have they gotten pills from anywhere else, or how many are they getting. That's, again, by law. You have to talk with the pharmacist. There's feedback with the pharmacist and family and friends. So all these things have to be done. And this will become important later on when we talk about doctors prescribing. But to me, this is not just the physicians. It's a shared responsibility for all of the people that we see that came here today. So law enforcement, the pharmacist, patients have obviously some obligation to share responsibility, as well as the drug companies and the physicians. So it's great to see a summit like this because we have all the interested parties talking about how we share the responsibility for this risk management. So how do people die of overdoses? Well, it could be accidental, that they just took too much of their medications. They could have comorbid conditions. They have COPD, sleep apnea. They took what could be a normal dose, but they're having an exacerbation and they stop breathing and they die. Most often it's combinations of medications, whether it's prescribed medications, over-the-counter medications, or alcohol. Okay? Those all exacerbate the respiratory depressant effect of it. Also combined with illicit drugs. So if they're taking mom's oxycodone, but they're also doing fentanyl or heroin or something else, or that's a problem. But out of those 18,000 deaths per year, we don't really have data on how many fall into that category, how many are accidental, how many are suicide, how many were combined with these things. So it's very difficult to assess that because we don't really have good data on those things. But in any case, we see on this graph the opioid deaths are on the increase. And we're going to get into this in much, much more detail. But here's an alarming thing that nobody talks about is benzodiazepines, okay? Teresa can confirm this. Every time we pull up a prescription drug monitoring bill, it lists all the controlled substances that those people have. And it amazes me that almost every single patient is on Xanax, Valium, or some kind of sleeping pill. And if you look at that red, the purple thing is how many deaths with benzodiazepines alone. It's not a lot. But if you combine that with opioids, which is the red line, it's exactly that. So this is really one of the deadly things. It's not just opioids alone. It's that combination of benzodiazepines with this. It's really a problem. The withdrawals, you talk about withdrawals from opioids, withdrawals from benzos are way worse. And this is a problem I think that we need to be addressing. This is gray death. Everyone know what this is? Okay. So this is the combination that's on the street now. This is the fentanyl, heroin mixed with all the other stuff. This is the new bad boy on the block. Illicit fentanyl and the derivatives, okay? So on the left there, you see a pill press that's used to manufacture counterfeit pills. There was a doctor down in Vero recently who was found with a pill press in his garage making fentanyl heroin pills, which are on the right side there. So those are pressed to look like oxycodone. So they're selling them on the street as oxycodone, but they're laced with fentanyl. But people don't know this, so they're crushing them up, swallowing them, and they die. Fentanyl is a very, very, very potent opioid. Carfentanil, which is basically what they call it elephant fentanyl, just nanograms of that stuff can kill you. So the DEA has found that basically almost all of this fentanyl is coming from China. So it's coming from China and going through Mexico or Canada or sometimes directly into the United States. So this graph is what we looked at before, and if you see the commonly prescribed opioids, that black, sorry I don't have a pointer, but that black line in the middle are those semi-synthetic opioids that Dr. Erfer talked about. So methadone, hydrocodone, oxycodone. And you see heroin starting to rise up there. The end of this graph is 2015, which is 2014 data. This is 2016 data. See that orange one up there? That's fentanyl, okay? It has literally gone almost straight up. It surpassed heroin and the other synthetic opioids by far in 2 years, okay? So this is a drastic change in what we're seeing. And this is, I've talked to some of my DEA sources as well as some of the narcotics officers, and they said, how much oxycodone are you seeing on the street in arrests? He said, I don't know, probably not much, maybe 10%. Most of it now is fentanyl, heroin, and Molly's ecstasy. So those seem to be the big three. I'm sure law enforcement is going to talk about this. So this data actually is pretty interesting because if you look at, this is pretty recent data, 2017, and this is unintentional overdose fatalities in Ohio in 2017. If you look at fentanyl, okay, the 250, but that 90 is 90%. So 90% of those overdoses in 2017 had fentanyl or any of those fentanyl analogs underneath it. And if you look down here, hydrocodone, oxycodone is about 10%. That's exactly what we're seeing here locally. So we've gone from this opioid epidemic of oxycodone to now we're dealing with a completely different animal that's way more deadly. So the CDC, everybody knows what the CDC is. They looked at this, so they've been following this opioid crisis and doing a lot of studies. And their conclusion basically says that the physicians are actually doing a pretty good job. We're seeing much, probably at least 13% per year decrease in opioid prescribing, about 40% overall. So they're doing fairly well. because of this issue which started about 10 years ago in Florida, we, our pain society, I was president at that time, we're trying to get this prescription drug monitoring bill passed and other things. So as a reaction to that, we do have state regulations. Recently, we had a bill which just passed in July 1st. We have mandatory access for that prescription drug monitoring. So every single time a prescription is written, that has to be accessed. There's limits on morphine equivalent dosing. We'll get into that in more detail. There's a 3-day limit on acute pain. So if you've had an acute injury, your physician can give you 3 days of pain medicine. In an exemption, they can give you up to 7, but after that, you're no more. Mandatory CMEs, so all the physicians have to take mandatory CMEs. I think this is a great idea because the majority of pain medicines are actually prescribed by primary care, not pain management physicians. So it's really important that they do get the education. The CDC guidelines, which we're going to go into a little more detail. DEA's increased prosecutions for physicians as well as patients. Pharmacies are seeing reductions in supply. The DEA has brought down the number of opioids that will be produced and distributed. And a big problem is physicians refusing to prescribe. I can tell you from being one of the few everyone's nodding their head, one of the few pain management doctors here, almost every primary care doctor, as well as some of the specialists, will now refuse to prescribe opioids. Say, sorry, can't do it anymore. And so they're all knocking on the pain management doctor's door, which I can't take on 500 physicians' patients. So it's a problem. So the result is this opiophobia, okay? So that's why we're all here talking about this. So the CDC guidelines, is everyone familiar with these? Very few, okay. So the CDC kind of looked at this whole opioid crisis and they put a ton of resources and money and they came up with about 11 recommendations, okay. The scope of these guidelines, which clearly states that this was intended for primary care physicians, okay. So people that are not trained in pain management or not specialists in this, were looking at, because they were treating the majority of it, and so that was one of the things that I wanted to point out. The second thing, one of the 11 recommendations, number 5, is they looked at overdose risks. And what we talk about is a morphine milligram equivalent. So if you have morphine is 10 milligrams or 15 milligrams, you have other drugs like fentanyl, oxycodone, hydrocodone, and they basically adjust the dose. So 10 milligrams of oxycodone would be equal to 15 milligrams of morphine. So you base your morphine equivalents on that. So they said that at 90 morphine equivalents is kind of where we start getting into high dose. And if you're going to exceed 90, then you need to document why and make sure that you titrate from there. And there's pretty good evidence because at that dose, we start seeing increase of overdose deaths and problems like that. So that's where that number came from. So a friend of mine, Sandy Silverman, he's been very actively involved with me, and he's also an addiction doctor and pain doctor. We're starting to see problems with this now. So very recently, because March of this year, 2 years after the study came out, CDC themselves looked at this and said, you know, I think we have some data issues here. The overdose deaths that we said are probably really inflated because all the fentanyl, the illicit fentanyls and the other things were actually included in prescription opioid overdose deaths. So the things that we were seeing all along, and the other issues, when you see these overdose deaths, it's pretty rare that there's only one substance in them. There's usually oxycodone, hydrocodone, cocaine, fentanyl, heroin, alcohol, Xanax. So every single one of those substances is listed as a cause of death. So if the patient really died from a heroin overdose but had oxycodone in their system, oxycodone is listed in that as well. So the prescription deaths were probably very much over reported. So we talk about the pendulum. So we had liberal use of opioids, and now we're restricting opioids, and we keep pushing that. And so there's always unintended consequences, whether it's a political movement or legislation or whatever. And so we're going to talk about some of those things, because I'm speaking from a medical standpoint, and this is an opioid thing. Insurance refusals. So every day I get people that have cancer. In fact, I have a friend of mine, a very dear friend of mine, who was a pain management doctor who had cancer. He was dying, he did die, and the pharmacy would not fill his prescription. And the diagnosis on the prescription was cancer. And so you're having insurance refusals to fill opioids. CVS nationally has come up with their rules. They will limit their prescription to 7 days for acute pain, whether it's regulated in that state or not. That immediate release formulations must be given before going to extended release. Third is that they will not release more than 90 morphine equivalents per day. So whether you've just had a huge back surgery, major trauma, something where you need more than that, it's just not cutting it for you, they will not fill it. So legislation, we have Aaron Grawl here. He'll talk a little bit about this. So everyone remember this game, Whack-A-Mole? Okay? So I talked about this years ago, when 10 years ago, heroin was pretty high. And then when enforcement started coming down on heroin and we had the big war on drugs, all of a sudden oxycodone came up. And so now these people, when they're addicted, and Leanne talked about this, they're going to get whatever drug they can to stop that withdrawal. So if you take away their oxycodone, they're going to do something else. And that's what we see here. So this is a graph, and you see the blue is oxycodone. And the black line coming down is when we had dispensing limits and abuse deterrent OxyContin came down. And you see all of a sudden that oxycodone use drops precipitously. The green is when we had the pill mill strike force come out, another kind of a drop there. And then when House Bill 7095, which was kind of cracked down on the pill mills legislatively, you see the OxyContin just come off. Then you see the big black graph up there. Guess what that is? Fentanyl, okay? But look at the deaths, okay? So you have the addicts that were taking these drugs. We take away their OxyContin, you whack that mole, and guess what? The other one comes up, but this one's more deadly. And so this is what we're seeing here. Prosecution against physicians, okay? So this is the DEA, this is actually a publication 22 pages long of all the physicians that are arrested and charged with stuff, which I'm okay with that. She knows. There are bad doctors out there, not a lot, but they're bad doctors, and they do need to be punished. But there's more pressure on the physicians not to prescribe, and we're seeing that. There's a lot of lawsuits for physicians for overprescribing. If you've had a patient die and your name is on that bottle, that doctor's scared to death, okay? The lawsuits against the pharmaceutical companies are billions of dollars that they're paying in fines. And criminal charges for physicians against patient diversion and abuse. So if you give the patient a legitimate prescription and they go out and sell it, the physician can be liable for that, as well as practicing outside the standards of care. Criminal charges against physicians for manslaughter. We see that all the time as well. So the scales of liability have changed too. So physicians are now scared of writing prescriptions, getting in trouble. And these are all physicians that are, so we have this problem now in our community where physicians will not prescribe little old granny taking one tramadol a week, and the primary care physicians who've been prescribing it for 5 years will no longer prescribe it. So again, those unintended consequences by pushing the pendulum too far, we're going to start seeing. And those intended consequences are real. There are our family, there are our community. So we need to strike a balance. So I say this one, this is what I feel like every day. You know, you're damned if you do, you're damned if you don't, but you got to pick one way or the other. So we have this scale that's balanced, and there's a lot of people holding it up. So we have law enforcement, pharmacy, legislative, people, families. We all need to come together and strike the right balance with this, and that's the end. So.
Thank you, Dr. Cordner, for helping us understand the scope from beginning to where we are now. And hopefully we'll hear more about that and striking some of that balance. So as part of our summit today, we definitely wanted to hear from people who have lived this. So we have two testimonies today, and our first one is coming up next. So Patty Oliver, as a family member, is going to come give us her perspective, and we thank her for being willing to do so. Patty.
Good afternoon. When I was asked to share a very personal and traumatic time in my life, I thought it would be a great opportunity to make the point that addiction can touch our lives in one fashion or another, even when you're adamant that it's never going to happen. And I was of that mindset that I could never imagine that something would touch my life like that. But several years ago, I was teaching life skills in our middle schools, and this is a program educating our children about the dangers of smoking, alcohol, and drug use. I've always been very passionate about teaching our youth the importance of a healthy lifestyle, especially abstaining from smoking, alcohol, and recreational drug use. My introduction to the drug unit was to ask the kids to write a paragraph describing what they thought a drug addict looked like. Most of the kids included the words homeless, or crazy, or criminals. My goal was to get them to understand that mothers, fathers, professionals, anyone can potentially become caught in the web called addiction, and that bad things do happen to good people. Ironically, it was during my time teaching life skills that my world collapsed due to opioids. I've always prided myself on taking care of myself, my health, and the people that I spent time with were of the same mindset. As a divorced mother of two boys, one who had special needs, I assumed I would never be remarried. And then I met a man who never had children, and after a year, he wanted to get married and become a stepfather to my two boys. I was very honest with him about the challenges of living with a child who was nonverbal, as well as having many health and lifelong challenges. It's not easy. And I didn't want him to feel like he was a bad person if he decided that he didn't want to do it. But he really believed, since he couldn't have kids, that perhaps God put him here to help me with mine. So over the next 5 years, he was a loving, compassionate stepfather who was very, very involved in their lives. He never once complained about the difficulties, and in fact, he showed he truly loved them like they were his own. And in my opinion, that made him an incredible person. Then a turning point. He ended up with a severe shoulder tear requiring surgery. He was given Percocet, and what we didn't know at the time was that this was the beginning of the end of our happy existence. He was a very hard worker, had a very physical job, and returned to work right away because we needed both of our salaries to continue to pay for the bills. I witnessed him popping 3 Percocet at once, and when I questioned him, he shrugged it off, saying he was in pain and he needed that amount to continue his work. I recognized the red flag here, and I reached out to our primary care physician, who gave me a script along with a schedule to try to wean him off of the pain medication. I doled out the pills according to the instructions, not knowing he was already buying Roxys off the street. For those who may not know, the Roxys are a synthetic heroin and extremely dangerous. I started to see distinct personality changes in the person who was always thoughtful and patient. There were subtle changes in eating and sleeping habits, and I knew something wasn't right. So my heart and my brain were in the midst of this tug of war, because in my heart, I knew that this guy would never abuse drugs. I knew he would never do this. But with my background in education, I was highly suspicious because of the changes. And then there were signs I couldn't ignore, like when I was in a parent-teacher conference and he nodded off in front of the teacher. Or when we were on the motorcycle for an hour and a half, we stopped for lunch, I looked across at the table, and his eyes were pinpoints and mere slits. Not only I realized that he was risking his life and mine, but everybody else on the road. When I worked up the courage to confront him, we had our first real argument in 5 years, and he was so convincing in all of his denials. By the end of it, he had me feeling guilty for accusing him of something so terrible. I still felt the need to start doing some digging, and I started with the financials. And there it was, $300 a day being withdrawn. Bills were starting to pile up, and at one point the water and electric was shut off. When I rooted through the garage, I found countless empty pill packs strewn all over the top shelves, along with a few stashes that he forgot about. I distinctly remember standing in the garage, looking at all of these pill packages, and in tears when the realization was this amazing person has become a drug addict. After the initial shock, I realized I needed to help him. I called his sister to help me convince him he needed help. After very painful discussions and arguments, he agreed to seek help. So I put $4,000 on my credit card for a week of treatment. It was only 2 days before he was back popping pills. Another shock was when I found out that all of these drug buys were here in Sebastian, right in front of a local convenience store. I funded a second stint in rehab, and by the third, I issued an ultimatum. By that time, a guy came to the house, who I had never seen before, said, "You better watch your back, you and the kids, because he's stealing, and he owes a lot of us money." So the ultimatum was he either spends 60 to 90 days in residential treatment, or the boys and I would be gone. When he stated he didn't have a problem, and he said, "I'm not like those people," I did one of the hardest things I've ever had to do. I packed up my boys and what belongings I could, and I left. It especially hit my special needs son hard, because he grew to love him. And then suddenly his house, his room, his pets, everything disappeared. And he never could understand or comprehend why. As the weeks went by, we were still communicating. I offered to go to meetings with him and went to one. However, he didn't continue to go. His behavior was becoming noticeably more erratic. All the while, he sounded so convincing that he was clean. I remember discussing the situation with a police officer who asked me, "Are you and the kids safe?" And I shot back, "Of course we are. He'd never hurt us. He's never raised his voice to us." Fast forward a few weeks when I noticed him following me home. He called while driving and said to pull over. I could hear in his voice that something wasn't right. I told him no and kept driving, and I could see anger in his face in the rearview mirror. I stopped at the intersection of Barber and 512. It was 4:30 in the afternoon, and I heard him rev up the truck behind me. He slammed his truck into my car, through moving traffic, and down into the small ditch. There were several witnesses who started to run over to assist. He ran over, trying to get me out of the car, saying, "I'm going to kill you. I'm going to kill you," over and over. He looked and sounded like a maniac, unrecognizable to me. What hit me was, he didn't know or care whether or not my son was in the vehicle. I am to this day grateful for the men who ran over to prevent him from getting to me. And his response to the police when being arrested was a simple, "My foot slipped." My car was totaled, my spirit was coming, and as my spirit, coming to the realization that the person I loved and trusted was a full-blown heroin addict, and that while under the influence, he wanted me dead for leaving him. It came out soon after that he told his work partner the night before the incident he was going to go to his father's house, get his gun, and come back and shoot me and the boys. He did go to get the gun, but luckily weeks prior, when I realized he had a problem, I called his sister and I said, "Please take the gun from the father." And it wasn't because I thought he would hurt us, it's because he threatened to hurt himself. He was sentenced to 3.5 years in prison. He got out early and was caught in Sebastian at a crack house. So on the violation, he had to finish his time. He's out somewhere in Florida, and I sincerely hope he's found his way back to being the person that we knew and loved. I have left out many details, but I'm sharing this, and it's to try to reach anyone in the community who believe that it's never going to happen to anybody in their lives. The sad truth is, our beautiful little slice of paradise here in Sebastian is no different than anywhere else. There are people buying and selling illicit drugs and overdosing from them. Bad things can and do happen to good people. No one sets out to become an addict. There's a crossroads that many addicts eventually face, and that is death or prison. And in this case, we were blessed because no one lost their lives. My 33-year-old niece, however, was not so lucky. 4 years ago, her 4-year-old daughter, my great niece, found her just after she died from an accidental overdose. My retired 62-year-old brother is still mourning the loss of his daughter and having to become a father to his 3 grandchildren. If your gut tells you that your teenager, that your sibling, your spouse, a friend might have a problem, chances are you're right. Don't feel guilty for questioning them or noticing changes in their behavior. If you're wrong, you can apologize. You can say, "I'm sorry, it's because I love you." If you're right, you have an opportunity to save their life. A very big positive is that in our community, we have an awful lot of resources. Find out what they are, and if you have any doubts, please call, because you might be able to save their lives. Thank you for listening.
Thank you, Patty. As you can see, the title today is an equal opportunity destroyer, and that testimony helps us to see that it can indeed touch any person anywhere, and that's what we wanted to help convey, is that this is indeed a disease, and that we do indeed have resources. Dr. Cordner referenced it being a multi-pronged approach, so our next speaker is going to be Chief Keith Touchberry from the Fellsmere Police Department, to give us a perspective from the law enforcement side. Thank you so much for being here.
Patty, I'm sad and happy I have to follow you, because that was a tough story to hear, and thank you for sharing it with us. And I'm happy to follow you because your story exemplifies a lot of those things that we see firsthand in law enforcement when we're dealing with family members. And the last thing you said about if you confront them and you're wrong, you can always apologize. And what we see all too often in law enforcement is there simply is not enough confronting going on, because I think we're in denial when it comes to our own family members. We want to believe that it couldn't happen to them, couldn't happen under our roof, certainly not under my watch as a parent. And but unfortunately, the sad truth is many family members will enable their loved one to do those things that they do. And no one wants to see their loved one get arrested. And that's typically what law enforcement is viewed as, is the person who's going to come and take away your loved one because they have an affliction that they can't control. And so as a result of that, law enforcement is really in the midst of a paradigm shift. And I say that because we have approached this problem for years, for decades, with a very crime control-centered approach. Now, I start my 30th year in law enforcement next year, and 25 of those years was with the Vero Beach Police Department, and the past 5 as the police chief in Fellsmere. And I can tell you that when I was a young rookie officer out there looking for DUI arrests because they were plentiful, alcohol seemed to be the biggest problem, and maybe some marijuana. But then in the mid to late 80s, we started to see these polydrug cases coming in front of us, where not only were they drinking, but they were taking Klonopin, another depressant. So we've got an additive effect when we're dealing with that. And then the prescription meds just continue to take a hold. Cocaine has always been there. Marijuana has always been there. But one of the problems we're seeing now as a result is a resurgence in the use of heroin. And not just heroin, but heroin that is mixed with opioids, in particular synthetic opioids. And so to kind of put the problem in perspective, and I've seen some data, it was good numbers. The CDC estimates that in 2017 there were 70,000 opioid-related deaths in the United States. 70,000. 30,000 of those were caused as a result of synthetic opioids. So that's a nationwide statistic. One of the reasons I'm here today, not just as a police chief, is I'm a member of the local regional opioid task force, and there are some other members in the room that are part of that task force. And I am the current chairman for the Public Safety Subcommittee, which is comprised of law enforcement agencies throughout the 4-county area, EMS and fire as well. And so we meet on a monthly basis. We actually just had our Public Safety Subcommittee meeting yesterday, and getting everybody up on board with a software called OD mapping, and that is how we can track overdose deaths or deployments of naloxone in our communities. And the city of Sebastian has been updating theirs regularly. But just to give you some statistics, because we know that this is a problem nationwide. I can tell you from my experience and in interaction with my colleagues at our Florida State Police Chiefs conferences and so forth, the areas that are hardest hit in Florida are your large metropolitan areas, like you can imagine. Palm Beach County in particular has come into recent attention due to the opioid task force and the state attorney that was in charge of that. And that brought about a lot of the legislation that I know Representative Grawl will no doubt talk about later this afternoon. And there's more legislation to come because the Senate overwhelmingly passed some stuff, about $8 billion worth, that hopefully if they and the House can get together, we will get some more money out here on our streets. But let's talk about some local numbers to put some of these things in perspective, and just trying to understand the scope of the problem. Last quarter, for example, Port St. Lucie Police Department administered 13 doses of naloxone, and 12 of those were successful. 13 and 12. Martin County was a close second with 9 administered and 8 reversals. Stewart Police Department with 8 and 5. St. Lucie County with 8 and 6. And that was the first quarter of this year. So we can see our numbers in this county are 5 and below. And we thankfully have not had any naloxone uses in the town of Fellsmere. We're typically an alcohol community, and there's definitely cocaine and marijuana present. We do have some intravenous drug users with opioids, but nothing to the extent we're seeing anywhere else. In this past quarter, April through June, the numbers in Martin County increased to 21 and 21 respectively, administered versus reversals. Port St. Lucie a close second with 17 and 17, and St. Lucie with 10 and 5, and again, our county here 5 and under for the respective agencies. So that's what's happening on the streets. Regionally, we defer to our medical examiner when it comes to data. And we know that last year, nationally, there were 70,000 deaths attributed to opioid overdoses. So with that number in mind, let's look at last year, for example. Fentanyl contributed to 36 deaths in the 4-county area. So I'm not comforted by that. One death is too many, but it certainly pales in comparison to what we're seeing in points south of here with Palm Beach, Broward, and Dade counties. But I want folks to understand that this is a very real number. The data that we get from the medical examiner is typically about 10 weeks old. 10 weeks behind, I should say. It takes about 8 weeks to get the toxicology information back from the Wusthof lab in Brevard County, another 2 weeks perhaps to generate the report. So the numbers I'm sharing with you is about 7 months worth of data. The year's not out yet. Currently there were 39 deaths where fentanyl analogs were contributing, and that compares to, that was 39 last year and currently 7. So we are seeing a decrease in those deaths, but we're only at 7 months of data for the year. But we are at 36 with fentanyl contributing to those deaths so far with 7 months worth of data as compared to last year, 36. So we've got 5 months of data collecting to go, even though we're in almost the 10th month. And we obviously anticipate the number of fentanyl deaths to surpass, last year's numbers. So that's a little bit about the data and the scope of the problem from a numbers standpoint. To talk a little bit to you about law enforcement's issues and concerns, when the crisis first began, we were hearing a lot of things about sober homes, patient brokering, and thankfully the legislative initiatives that took hold are going to be addressing some of those things. But those problems were very real. We weren't really seeing a lot of that in this county, but certainly in Martin County and somewhere in parts of St. Lucie County, we were seeing the patient brokering issues. We call those bad sober homes. There are good sober homes, and they are dedicated to patient recovery, but there are those that will take advantage of the afflicted and profiteer from their illness, and that's a big problem. So I shared with you the data. Let's go back to talking about the crime control approach. I was a young cop, and I know what it means and how it feels to take that bad guy to jail. And when we're looking at drug abuse and substance abuse from a crime control perspective, then that's what our goal is to put them behind bars, let the criminal justice system figure it out, and maybe we'll pick them up down the road, a week or a year or so later. Well, the paradigm shift that we're in the middle of now is we have to see this for the behavioral health problem that it is. And I know especially the treatment side of the house is applauding that shift on our part because they want us to partner with them in understanding the behavioral health problem behind opioid addiction. And so as a regional task force, we approached it from a regional sense with Treasure Coast Chiefs of Police. And the first offer that we made was, if someone were to come into our lobby, Bruce Colton, would you, and say, hey, I need a problem, here's my dope, will you please get me help? And if that was a good faith effort on the part of that individual, then Bruce Colton said, absolutely, we'll defer prosecution, let's get them the help that they need, even though they are committing a crime when they walk into your lobby. So that opportunity is there. The treatment side calls that a warm handoff, so we will hand you off to where you can get that help. And I know we'll hear from some other folks about mental health court and so forth. That is another viable option for us. We have a young lady in Fellsmere, for example, that she's bipolar, and she doesn't like the treatment plan that her doctors put her on, so she puts herself on her own treatment plan. And she doesn't work, so she has to earn an income somehow, so you can only imagine how that is. And so when we deal with her time and time again, committing crimes, it becomes just a vicious cycle. And so making one phone call to the state attorney to say, look, we need to shift this person over to the mental health side because the crime control model is just not working with her. Prison time is not going to fix her. And so she's currently undergoing that treatment, and we hope that she succeeds because the last thing we want to do is have to continue to put handcuffs on people. And I say that with a great passion because the last thing any law enforcement officer wants to do is arrest somebody or to go to repeat calls for service. The first and foremost issue that we have with that is the officer safety side. There becomes a sense of complacency when you're dealing with that's just so-and-so. It's a repeat problem. And so you become complacent and you let your guard down, and then somebody gets hurt, or we have to react in a manner that we don't want to and use force and so forth. So we don't like repeat calls for service, and we don't like to have to take people to jail, and we want alternatives to dealing with this problem. And that's why we are dedicated members of the Opioid Task Force in the Treasure Coast. So just to give you a little mindset on, if you will, on the anatomy of a criminal investigation, because there are a lot of folks that they just don't understand what we're dealing with, and they just want to see people go to jail, and why aren't you cops doing your job? You know, go arrest the drug dealers. Well, that's a good place to start. We'd like to do that. But there's also the argument that there wouldn't be a supply if there wasn't a demand. And so we have to understand the reasons why we have this demand. And so we can go out and we can arrest drug dealers, but we have the Constitution that we have to follow. We can't just go, hey, you look like a drug dealer standing on a known, street corner, you're coming with me. I mean, investigations can be lengthy. When you use someone as a confidential informant, for example, this is typically someone who's a user, but they're willing to assist you either because we've got some mean and nasty charges hanging over their head, or surprisingly, some of them out of the goodness of their heart really do want to make a difference, but there's always an angle. Do you think confidential informants are reliable? They're not. And I've got to tell you that if you watch any crime dramas on television, Hollywood has done policing the largest disservice ever, because it just isn't like you see on television. Drug investigations are not glamorous. They're nasty, dirty, investigations, and we don't deal with the best, highest caliber of people in society, but they also have problems, and we understand that. So they're not reliable. And when we go and we do these drug buys and we get probable cause to search wherever it is that we can tie that drug sale to, we can't use that informant if we want to keep them confidential. So we're not going to get any criminal charges that we could if we were using an undercover police officer, because that sale charge, we're using that to search your RV or your house or your car or whatever. And then we're hoping to get those criminal charges stemming from that. But guess what? You shut down one drug dealer on one corner, what happens? Another one crops up. And we go back to the law of supply and demand. So we have to understand the origins of the demand. And I think what I'll do is I'll close with this statement, and I really would like this to resonate more than anything else. Crime is a social problem. It's not just a problem of law enforcement. It's not just a problem of your government. It is everyone's problem. And just like we've been saying in the wake of 9/11, see something, say something, we have got to depend on our neighbors and our family members and our friends to do the right thing. And I'll give you a quick story. I can't arrest somebody unless you help me sometimes. And it's a simple burglary where I got this woman, she had some evidence, and she said, I thought it was stolen, I just wanted to show it to you. Well, guess what it was? It was taken from a burglary in a car 3 blocks from you. Poor little 18-year-old girl's getting ready to go to UF next year, and everything she needs to succeed at UF is in that computer. We can get a search warrant right now if you come down here and give us a statement. I don't want to get involved. I just don't want to do it. Okay. Well, in 1962, and you're familiar with the Attorney General back then, Robert Kennedy, he wrote a 24-page long statement about crime in America. And he said that society gets the kind of criminal it deserves. And what is equally true is communities get the kind of law enforcement they insist on. And what we're referring to here are two things: the social contract on the back end, and on the front end is a theory where the broken windows theory. Society does get the kind of criminal it deserves. If we go through life like this, and we see nothing, and we don't say anything, well, then we're going to get the kind of criminal that we deserve in our community. But if we do see something, and we do say something, even if it's a family member, knowing that there are all these caring professionals in our community who can help, not just law enforcement, well, then maybe we can do something about this epidemic. So I'll close with that, and please see something if you say something. And remember, crime is a social problem. Thank you.
Thank you, Chief Touchberry. Our next speaker is Nicole Mins. She's an attorney in Indian River County that practices criminal and family law, and she is going to, one of the things we heard as a committee is how much legal issues affect families that are going through this, and so she's going to give us some insight into that. Thank you, Nicole.
Thank you, Teresa, and thank you, everybody, for inviting me. I do also sit on the board of directors for the Substance Awareness Center, and it's one of the things that I'm most proud of in addition to my law practice. I have a PowerPoint. Oh, it's up. Magic. All right. So the Journal of American Medical Associations issued results of a study this July, and it was the first national estimation where they were trying to figure out what percentage of the people that are in the criminal justice system are there because they are opioid users. And it's the first time that a national study had been done, and they surveyed 79,000 people. And what they found out was that prescription opioid use disorder, people that had that, were 20% more likely to become involved in the criminal justice system. Heroin users were 40% more likely to become involved in the criminal justice system. And people who had never used opioids, they're only 3% likely to become involved in the criminal justice system. So when we're talking about what it is that we see, and from my perspective as an attorney, the charges that we see are these. They range from simply possession of a controlled substance if you don't have a prescription, possession with intent to sell, and then trafficking. All three of these are felonies. Simple possession of a controlled substance. You're in possession of one hydrocodone pill that does not belong to you. That's punishable by up to 5 years in prison. You're in possession of pills that you intend to sell to someone. Depending on what that drug is, that's possession with intent to sell, punishable by up to 15 years in prison. And then there's trafficking. And trafficking isn't like what we used to think it was, like Miami Vice, where we're talking about drug cartels, and they're bringing in large shipments on planes, and they're bringing in large shipments in trains. Trafficking is actually defined as selling, purchasing, manufacturing, delivering, or simply possessing a certain weight of drug. And that's what we find most often. Florida, we have mandatory minimum penalties for trafficking in controlled substances. It's one of the few charges where we actually have mandatory minimum penalties. The legislature reduced those a little bit in 2014, and so what you see on the screen before you is the mandatory minimum penalty for hydrocodone. So to give you an example of what 14 to 28 grams of hydrocodone might look like, when we're talking about the weight of the pill, we weigh, for legal purposes, the entire pill. We don't fraction out what it is that's the illicit substance, right? In a typical hydrocodone pill, 10 milligrams of that pill is hydrocodone, 500 milligrams of that pill is acetaminophen. Nothing wrong with being in possession of acetaminophen, right? But the law says that no, you don't get to parcel out, so your pill doesn't actually weigh 0.25 grams of hydrocodone. It weighs the entire weight of that pill. So in order to have a trafficking amount now in the amount of 14 to 28 grams, you're looking at about 22 pills. So somebody who's in possession of 22 pills, hydrocodone, that they don't have a prescription for, even if it's for their personal use, they're not intending to sell it, they're addicted to it, which is a lot of times what we see. People become addicted for real reasons, car accidents, on-the-job accidents. I represented a flight attendant who had suffered from, there was turbulence in the airways, she had a neck injury, became addicted to prescription pain medicines, went out on work comp, during that time became addicted, went back to work as an addict, could no longer get pills anymore, cleared by the doctors, buying them on the street, and it was then found in possession, to be in possession of 20 pills of hydrocodone. She's a flight attendant, a professional person, but she is trafficking under the law in hydrocodone. It's one of those charges where the judge does not have any discretion. 3 years means 3 years. It doesn't matter what you say to the judge. There is nothing the judge can do. The judge simply has to look at that person and say, 3 years in the Department of Corrections, and that's at a minimum. The judge can give anywhere up to the statutory maximum. So if you look at those, our minimum mandatories are 3 years, 7 years, and 15 years. And those are down from 7, 15, and 25. These are the mandatory minimums for oxycodone, and so what we're thinking of is Percocet. Again, the typical Percocet, it's only 10 milligrams of oxycodone. It's 650 milligrams of acetaminophen. So an example of how many of these, the minimum mandatories are the same, however, it requires significantly more pills in order to traffic in oxycodone. One of the new charges as of October 1st of 2017 is we now have the charge of drug-induced homicide. And we actually are just now starting to see that being charged in state court in Florida. They've charged that in federal court for years. In federal court, it was known as the Len Bias Act, if anybody are sports fans. He's the basketball player who overdosed just before he turned pro. I think it was actually like he might have gotten drafted and then overdosed. And he died, and they prosecuted the person who sold him those drugs. So the Len Bias Act has been in federal court since about 1986. But in state court now here in Florida, since October 1st of 2017, we have drug-induced homicide. And drug-induced homicide means this: the person intentionally killed someone, or counseled, or commanded, induced, procured, or caused the intentional killing of an individual, and the person did in fact die. But if you look at that or, the person's conduct in committing that act led to a natural, though not inevitable, lethal result. Because what is it that the defense you expect to be? Yes, I delivered those drugs. I didn't think she was going to take them all at once, right? I wasn't intending to kill her by giving her all of those pills. It's not my fault she's an addict and couldn't control herself and took them all, right? So that's actually built into the statute. Now, we don't have any cases pending in Indian River County for drug-induced homicide at this time. And there's two things that make this charge difficult for the state attorney's office, though I anticipate that these are going to start coming more and more frequently with the increase in fentanyl. The first thing is that the medical examiner has to be able to testify that the primary cause of death was in fact that drug, right? So the medical examiner has to be able to say, yes, it's as a result of oxycodone or hydrocodone or whatever that might be. And the second thing is that the law enforcement officer has to be able to prove who it is that delivered those particular drugs to that individual that overdosed. Now, if someone's convicted of this, it's a mandatory life sentence. Life means life, no possibility of parole. It's also punishable by the death penalty. And some people think, well, I did deliver the drugs. My friend just overdosed. I called 911 and I tried to render aid. Good Samaritan law is not a defense. Doesn't help you. You are still responsible for that death. So the Department of Corrections, in order to kind of give you an idea of how many people we're seeing being incarcerated as a result of drugs, this is from their 2016 annual report. And if you notice, drug offenses, people that are in custody, actually behind bars, make up 14.8% of the population. And if you look, that's just 0.1% behind murder and manslaughter. In 2016, the largest group of inmates that actually went into custody were for drug crimes. 6,000, just slightly over 6,700 people went into prison in 2016 as a result of drug crimes. That's 22.5% of the population in that particular year. And not only are they behind bars, but at some point they get released or they get placed on probation. 36,000, just under 37,000 people that are on probation for drug crimes are being supervised by the Department of Corrections. So those are some of the criminal problems that we're seeing. Some of the other problems that we're seeing are these, obviously. We're seeing on the flip side, the family side and the civil side, we're obviously seeing financial problems. What comes along with the conviction of a drug charge, whether it be you're convicted for 1 pill of hydrocodone or you're convicted of trafficking, a driver's license suspension comes along with that. That's mandatory. You must have your driver's license suspended for 1 year. So what we're seeing happening is that people, as a result of that driver's license suspension, are sometimes losing their jobs, right? Fortunately, now we have public transportation here in town, so it's getting a little bit better. We're seeing that the rehabilitation costs for families are driving families sometimes to the point of bankruptcy. So the financial repercussions that family members are suffering as a result of their loved ones being addicted to opioids is significant. The other area where we're seeing this is in our family cases, in divorce cases. And where this is most often used by one party against another is in time sharing. We don't call it custody anymore. In Florida, it's called time sharing. And so someone's substance abuse issues can be used as leverage against the other spouse to decrease time sharing. And so we're seeing that judges are finding, in the best interest of the child, the parent who's suffering from substance abuse issues is getting restricted access to the children, whether it be supervised or less time than they normally would if they were not abusing opioids. We have increased cases, as Bob said, in dependency court, the Department of Children and Family Services, and I'll talk a little bit more about that as we go down the road. And then the other thing Bob touched on was deaths, and then how it is that grandparents now suddenly get to raise their grandchildren that they never expected. And the majority of these people are dying without any type of estate planning documents, as you can imagine, right? So they never anticipated that they needed to appoint a guardian for their children should they pass away. They never anticipated that they were going to have to provide some sort of financial resources for their children if they were to pass away. Right? They don't anticipate that, and so they're dying without any documents, and now suddenly it becomes the state's responsibility. It becomes an older grandparent's responsibility. I wanted to give you some things, though, as family members that are available to you through the court system that actually you can do on your own, and the clerk's office is set up to help you assist you do those things. So I wanted to talk a little bit real quick about the Marchman Act. It's found in Chapter 397 in the Florida statute. It's our Florida Substance Abuse Act. It allows for the temporary detention for the evaluation and treatment of someone who's suffering from addiction. And I put on there who it is that can initiate, and I hope you can see it. Because you do not have to be a relative or a blood relative or a spouse for this particular act. As long as you are somebody who has independent knowledge of the substance abuse issue, you have the ability to file the paperwork to initiate getting that individual help. And you file that by completing an affidavit or a petition at the clerk of court's office. And they actually have the packet there. And they make it really, really easy for you so that anybody, that's why I wanted to tell you about this, anybody can actually go in and do that. And what you have to tell them the reason you believe the person is suffering. You have to say how that impairment has made them so that they've lost control of what it is that they can do. And the reason that you believe that they're likely to inflict harm on themselves or somebody else as a result of the addiction. And then that they're refusing to voluntarily enter into some type of help. After the petition is signed, what happens is that there's a hearing held within 10 days. And after the hearing, the judge can sign an order granting the petition, sets an appointment for an assessment. And then it's during that assessment that will determine what it is, whether or not, number one, the person's going to meet the criteria for involuntary treatment. If they do meet the criteria for involuntary treatment, what it is that treatment's going to consist of. That's actually an error there. The judge can actually order somebody into 90 days treatment involuntarily. At the end of that 90 days, if the particular treatment facility thinks additional treatment is necessary, they can petition the court for up to an additional 90 days. Now, These aren't lockdown facilities, and they also aren't free. So they come at a cost to the family members, right? So it's either through your insurance, if you have it, or you have to private pay. But they're not lockdown. So what happens if the individual you've involuntarily committed walks off the site? Well, because it's a court order, the judge actually has contempt powers, right? The judge can issue what's called a rule to show cause, can order that person picked up and held in jail until he or she agrees they're going to go back to treatment. And you can play that game as many times as you need to. The judge can hold somebody in contempt for as many times as is justified under the law. So that's the kind of the teeth behind this petition, is the contempt order. And the people sit in jail until they say that treatment's probably better for me than jail. A great resource, and maybe Bob can tell us if it's been updated since then, the Marchman Act User Reference Guide. It's actually dated 2003. I can't find a more recent one, and this is the one that I have. Is that the most recent one? Okay, good, because I'm like, surely I'm missing something. All right, so good. It's actually put out by the Department of Children and Family Services, their substance abuse program. It's a fantastic document. I encourage anybody who is struggling with these issues and you want to know where to get help, please look at this. You can find it online. It will walk you through everything. It is really a fantastic resource. A lot of times we're seeing substance abuse issues coupled with mental health issues, right? So let's say you don't have the ability maybe to testify, you can't figure out whether or not it's substance abuse related or mental health related. Another one of the services that are available to you, you can do this on your own through the clerk's office, is what we commonly refer to as a Baker Act. It's found under Chapter 394 under the Florida statutes. Now, to initiate a Baker Act, anybody over the age of 18 that has witnessed the actions of the person and you believe that the person is a threat to themselves or a threat to others as a result of some type of a mental condition, you can go in, complete an affidavit or a petition at the clerk's office and initiate a Baker Act. What happens then, the judge reviews that petition. The judge can then order that person picked up and held involuntarily for up to 72 hours so that an assessment can be done. Then, after that assessment is done, if the provider feels that some additional treatment is required, a hearing will be held where they have to prove that by committing them is the best thing for them, that there are no less restrictive means that would be available, meaning we don't believe that if we release them and tell him to take his medicine, he's going to do that, so we think we need to involuntarily place him. The judge can order placement involuntarily. The third is a guardianship. This is a little bit more difficult, probably requires the help of an attorney. This is by far the most costly of the options, unfortunately, because of the attorney services and because the person that you are alleging to be incapacitated. And when we're talking about a guardianship, what we're talking about is a judge finding somebody is incapacitated with respect to being able to care for themselves. And so there's a hearing that takes place. The alleged incapacitated person is entitled to an attorney, and you, by the person filing for that guardianship, must pay for that attorney. So this becomes costly. The ones that I'm aware of most recently ran in the neighborhood of about $20,000. That's just for the supervision of the guardianship, right? For everything that needs to be done. I'm not talking about the cost then of treatment and other services that are provided to the individual. So unfortunately, this is for those with more means than others, but it's something for people to be aware of because it's not used very often, and this is the mechanism that truly does have teeth, because what you're doing is you become the controller of the person's treatment, of the person's money, of the person's property, of the person's social environment. You can put those restrictions, whatever restrictions you want to or you feel that are in the best need of the alleged incapacitated person. You can have those put in place by the court. So I wanted to make that you all aware of that because that is not something that most people hear about. Oopsie, wrong one. All right, and so it's really the same thing. You file a pleading. Three people are appointed to examine the person. They have to find that the person truly is incapacitated. The guardianship lasts for as long as treatment is necessary. So the guardianship could last for years if treatment was necessary. It isn't a 90-day fix. It's not a 6-month fix. It literally can be for years. And we have in the guardianship where there are cases where grandparents are acting as guardians for their 40-year-old grandchildren. Parents are acting as guardians for their adult children. That's where we see it a lot. So I wanted to make sure that you all knew that that was something that was available through the courts. And then again, the Department of Children and Family Services. And this is what we see a lot of times, families that are just at their wits' end and don't know what to do. You can make an anonymous call to the Department of Children and Family Services, a call for services. And then what that will do will result in an investigation, the children potentially being removed from the home. Hopefully they're placed with a blood relative. And then the individual gets put on a case plan. And the case plan is there to address all the substance abuse issues that that one particular person might have. And the goal always is we want them to be substance-free because we want to be able to reunite them with their children. So as a last-ditch effort, a lot of times what we're seeing are people making anonymous calls to DCF because it's a way to at least start to get services into the home. So I hope that was helpful. I will be sticking around. If anybody has any questions, please feel free to come up to me in the back. I appreciate it.
Okay, so we are close to 2 hours of our 3-hour program. It's possible we will run over a little today, but we do have built in a break, and we would like to take that. But I would like for everybody to be back like 3:02. So just a 10-minute break. There are some light snacks out in the lobby, and the restrooms are out there as well, and our speakers should be around. Thank you. And ask that our speakers do the same. So under our second section, Finding a Solution, our first speaker is Brett Hall, who is the Executive Director of the Indian River County Mental Health Collaborative, and he's going to talk to us about levels of care and treatment options. Brett?
Thank you. Thank you. Good afternoon. It's always hard to follow the snack, so I'm going to try to stay animated so that you don't go to sleep. So I'm so fortunate to hear some great speakers this morning, or earlier in our program. It's going to be a hard act to follow, but I'm certainly going to try, and they really painted the picture on the scope of the problem and some of the issues surrounding the opioid crisis. So the second half, our post-snack program, will talk about solutions. There are solutions, and there is hope, and there is light on the other side. So we're going to get that. Again, my name is Brett Hall, as they said, with the Mental Health Collaborative, and I can tell you more about how we're helping the community screen and get referred into services. That's all we do. Just a nonprofit helping people get into services. And I'm here to discuss treatment options, levels of care. Some of this gets a little controversial. People have different opinions on what's the right level of care, or they should do this, or some people say, well, I had a relative that had a problem and they went into this level of care, so that's what everybody needs to do. Treatment it's not one size fits all. So I'm going to give you my perspective and my opinions just from my experience, my 25 years of experience. And the other thing I want to caution, I sat next to Nicole, an attorney, so I just have to, give the legal disclaimer. These are all just my opinions, right? So this is worth what you paid for it. And the other thing is, please don't get caught up in the lingo, because the language changes and evolves over time. Some real quick examples is back in the day, or years ago, when somebody went into a 28-day program, they went into a 28-day rehab, right? Rehab is really not the term we use anymore. Rehab is more like physical rehab. So we have hip replacement, we go to a physical rehab for that. Now they're called treatment centers, residential treatment centers. So just another example is we used to call them halfway houses. As a step down, they were halfway houses. Now they're sober living homes, right? So don't get caught up in the lingo. Not only do they change over time, but they change by location. I'm a Chicago native, so what we called things in Chicago are different in Florida. They're different on the East Coast, and they're different in California. So when you are talking about programs, services, don't get caught up in the language. Get caught up, ask what specifically they mean by that. So if they say, oh, we're recommending a sober living home, or you should consider a sober living, tell me what that means. What does that look like? What does that program entail? So I think you'll be much more clear doing that. So again, treatment is different for everybody. It's not one size fits all. What works for one may not work for another. Treatment is usually about timing, motivation, and fit. Is this the right time in my life? Am I motivated to really make these changes? And is the treatment that I'm seeking a good fit for me? As we all know, it's about fit. We have to feel comfortable, and we have to have faith in the treatment providers that we are surrounding ourselves with. And also the other thing before I get into what I'm actually supposed to do is I just want to throw that out there. We learned earlier that many people relapse. And it's the statistic that I pulled before I walked in was 40 to 60% of people that go through formal residential treatment will relapse prior to a year. So that's a lot of folks, right? And when I talk to, in the work that we do and working with families and screening and referring for services, we see loved ones and family members that get very frustrated. They say, they've relapsed. I'm done. I can't do this anymore. But, you know, so people think that once you go through treatment, you're cured. Once you go through cancer treatment, you're cured. Doesn't always work like that with addictions, right? So we say that relapse can be part of the disease process. That given time, many people will relapse. And I just want people to be aware of that, because it can get very frustrating. So I'm going to describe the different levels of care. How do you know which one's right for you, for your loved one, for the person that's seeking services? There is no great answer. There are standardized assessments that people can go through with treatment professionals, specifically the ASAM criteria. The American Society of Addiction Medicine has very outlined screening tools that the person can sit down, go through, and they will recommend what is the right level of care. It's the best guess on based on science, based on best practices, what they think has the highest likelihood of being successful. So a lot of professional treatment providers will use some of those criterias. But again, it's different for everybody. So let's talk about levels of care. I'm going to name them real quick, kind of from most restrictive to least restrictive, and then we're going to go back and talk about each one of those in a little bit more detail. So first we have a detox. We learned about detox a little bit this morning. That's a detoxification program. And then next we have residential treatment, usually your traditional 28-day. Partial hospitalization program, sober living homes, intensive outpatient programs, outpatient counseling, and then support groups, AA, NA, those kinds of things. So I've outlined them. Let's go back. Detox. We learned detox. Dr. Erfurt told us earlier that very few, if any, person will ever die going through opioid withdrawal. They're going to wish that they were. It's very painful. It's very ugly. And that is what we heard is what stops people from getting sober, is just the fear of going through that detox. And I'm just going to make a real quick side note because that's what I do. Although you can't really die from opioid withdrawal, alcohol is a whole different story, right? With alcohol withdrawal, there can be what they call the DTs, the delirium tremens, the pink elephant, they're hallucinating. It's a physiological response to alcohol withdrawal. 5 to 10% of people that have DTs will die. So alcohol is a different story. I just want to throw that out there, right? I know we're here to talk about opioids, but I just have to throw that in with alcohol. Alcohol detox for chronic and persistent, and alcohol use over the long term can be very dangerous. But detox is a part of many residential treatment programs. A lot of residential treatment programs will have a detox component to it. It is the first 2, 3, 4, 5 days of treatment in a residential treatment center. Residential treatment, and that's detox is the medically assisted. They use some drugs to physiologically work with the body to get the drugs out of their system, make them comfortable, make sure that their blood pressure is not too high, et cetera. So they make people a little bit more comfortable through the detox process. That next is the residential treatment, and that is the traditional 28-day program. That is generally a live-in facility they go to. They participate in groups, they participate in individual, they do different wellness activities. Every program is different, but they do all kinds of things to teach people skills so that they can live a sober life. All right, that's what the residential treatment program is about. And residential treatment and working with the different providers, it doesn't have to be 28 days. It can be 7 days. It can be 14 days. It can be 30 days. Some programs are up to 90 days. So don't get caught into what everything should be or what you've heard it's been. These are very individualized programs, okay? So from residential treatment, once they go through that, they can step down to what they call a partial hospitalization program. A partial hospitalization program is a 3, 4, 5 hour a day program, 4 or 5 days a week, right? So they're getting out of the residential treatment, they have a little bit more freedom. Sometimes they'll offer an overnight component where they'll offer them a place to sleep, but it's weaning them down a little bit, getting them back towards their environment and giving them skills and then the constant or the daily support to maintain sobriety. So we have those. With that, some of the programs will offer a sober living home that's attached to the partial. So they'll have a sober living home is what we used to call halfway houses. It is a facility in the community that's a sober, peer-run usually, so other people in recovery in the home, all living together, working together, figuring out and supporting each other on how to live life live a life sober. From there, we can go down to intensive outpatient program, and that's usually a 2 to 3 hour a day program, 3 or 4 days a week. So we're stepping it down. You can see the programs become less intense, and we're just weaning people off the constant support so that they can live more independently. IOPs are good. Intensive outpatient programs are good for folks. IOPs offer them sometimes at night, on the weekends, or earlier in the morning, so that it affords people time to work. Right, so we're working on, the whole point is we provide treatment to folks and then we wean them back in and keep some supports around them so that we can increase their likelihood of staying sober and maintaining their recovery. We have outpatient counseling. Lots of providers in town that do the traditional therapy, the outpatient counseling, the one-on-one counseling, talking with folks about relapse prevention plans, how are things going, those check-ins kinds of things. Lots of certified addiction professionals doing that kind of counseling. And then we, of course, have support groups, the NAs, the AAs, the Al-Anons, the different support groups in town. That provide a great service. There are some folks, generally for alcohol, that can go to AA, stop drinking, and then that's their intervention. There are some people that have tried that for opioids with NA. The results are mixed, but it is an option out there. So those are the treatment, the levels of care, and like I said, the ASAM criteria based on your assessment would say, well, based on your information, you probably should go into a partial hospitalization program, or you should consider residential treatment. That's what the formal assessments will say, but just know that you don't have to go generally based on, I mean, every individual is different. It's going to be based on the length of use, the intensive use, you know, where physiologically, where the body's at. But you don't necessarily have to go through every level of care. You can jump somewhere in the middle. You can, everybody's different. And treatment looks very different for everybody. So again, not a one-size-fits-all. So I just wanted to go through and talk about real quick the different levels of care and the treatment options that are available. There are many, many providers in town with all of these levels of care. Indian River being a small community, sometimes we have to use some outside resources, but there are lots of options. On the back table, there are lots of resources, for treatment providers, so take a look at those. And again, I alluded to the Mental Health Collaborative. We run the McCabe Connection Center, which is really just an information referral service. So if you ever had a question about anything, substance abuse, mental health, transportation, housing, anything in our community, just give us a call and we can help you work through those things. If we don't have the answer, we'll find it for you. We say that we are the personal assistant for 140,000 people in Indian River County, so use us. We've seen 1,800 people in a year and a half, so we're getting people where they need to go. So I'm going to introduce Stephen, that's wearing a lovely purple dress today. Stephen was unable to be with us today, but his boss, Vicki Soule, the CEO of Treasure Coast Community Health, is going to talk to us about there's lots of treatment providers out there. How do you know which ones are quality? Thank you for your time.
Thank you. Steve wanted me to relay to you all how disappointed he was that that his boss wouldn't let him come today, but it's for his own health and welfare. He will return to work soon. But I do want to thank Brett for your years of experience and knowledge with everyone. I know that everyone has a better understanding because of the levels of treatment. My name is Steve Hellier, and if you see the real Steve, you can tell him he looked lovely in purple, okay? Steve is one of our outreach coordinators for Treasure Coast Community Health, and he actually gave me a full script. So I could talk on my own, but Steve was so impassioned about this message that I promised him I would read it verbatim, but it is short, so bear with me. Steve has been working with people in recovery and their families for close to 5 years now. I am very passionate about my mission. I want to share with you all now what to look for in a good treatment center and some things to be aware of during your search to get you or a loved one help. I want to first let you know that if you haven't been through this, it will be some of the toughest times you will face. Going through this or seeing a loved one struggle with addiction will wear you down to your last bit of strength and resolve, but you will get through it. Prior to beginning your search for treatment, I want you to know that there are resources in our area that will help you. This is their mission, and there's no reason to go through this alone. Listen, for a long time it was those people who struggled with addiction, not me or my family. Well, let me be the first person to break it to you. It is everywhere. It is from the poorest amongst us to the richest and most powerful people in the world, okay? The resources we have in this county that will help you now, know that, and there is no judgment, period. No judgment, period. This is a mission of these fine people, so please use them. The Mental Health Coalition, the Substance Awareness Council and Coalition, AA, NA, CA. Seek out the help from those people. They stay clean and sober by helping others find it and be successful at it. Treasure Coast Community Health, your local law enforcement agency, they know who to get you in touch with. They know the people that have done the vetting of different centers. Please understand that the person struggling with addiction has to want to get off to better themselves. And these are all in caps. Outside influences cannot be the only reason. They have to want it more than anything and put it ahead of anything. When looking for a treatment center, know that there are a few things that you need to make sure the center has. First, licensing from DCF, Department of Children and Families. DCF licenses and oversees all of the treatment centers in the state of Florida. Secondly, accreditation from one of 3 major accreditation agencies. These are in addition to licensing and have a very strict list of requirements that these centers are required to have in place and follow. They are audited every 1 to 3 years, and they're held accountable to standards. There's no wiggle room to be less than on point with the programs they offer. These agencies also go through data to make sure that the centers do what they tell their patients and families they are going to do. These are all nonprofit accrediting bodies that are there to hold centers to very high standards. These are not easy accreditations to receive and really show a commitment to doing things the right way. These include CARF, the Commission on Accreditation of Rehab Facilities, COA, the Council on Accreditation, and the Joint Commission. Next, make sure they have licensed staff for the treatment that's being sought. Ask them, do they have the following staff members? An LCSW, a licensed clinical social work, or an LMHC, again, all these acronyms, a licensed mental health person, a psychiatrist, a psychologist, RNs or LPNs, and as was mentioned earlier, certified peer recovery specialists. Ask them also about their group sizes and activities. Make sure their idea of group is not to put 50 people in a room with a DVD player and call it a therapeutic group. This doesn't work, and it won't get people sober or help them stay sober. Small, professional, or certified peer counselor-led groups have the greatest success. Ask also, how much one-on-one time will patients get with their therapist or counselor? This is when the heavy lifting is done. This is when the monkeys get knocked off the backs. If we don't get the monkeys off the backs, we can't get well because the monkeys are always going to be there. Ask too, what's the average length of stay? And what is the AMA, or against medical leave, discharge rate? Make them answer these questions. A well-run program that's there for the right reasons will be honest with you, and they won't try to hide or sugarcoat the truth about their facility. This is a very difficult mission field. Centers and people fail more than they succeed, as Brett pointed out, but the programs that last and do this the best understand that. They will try to help everyone, but understand that they can't let the ones that fail keep them from helping the next person that wants to get well and giving them the best possible option to succeed. I want to finish up for Steve by bringing to light the things to be aware of and watch for that can clue you into a less than reputable center. And this is from his own experience, and I think many of us in this room probably are aware of this, but for those that aren't, watch for big flashy advertisements promising everything from in-house training centers with state-of-the-art workout facilities to weekly paddleboard and kayak expeditions. Watch for the places and people that make promises of things to you, such as buying you airfare, clothing, free room and board, paying you even for your insurance if you're uninsured. And these are not exaggerations on his part. I personally have talked to several people who come down from up north with these promises. Understand that treatment centers are not allowed to do these things. This is called enticement to treatment and is highly illegal. Get to know the area that you or your loved one is going to treatment in. Make sure the center is what is advertised. There have been a lot of instances where centers are advertised as a Taj Mahal and end up to be a small 3-2 house in a terrible part of town without any of the amenities that have been advertised. This is also highly illegal, and the best way to put a stop to this is to make it be known. And again, we think of this, I will editorialize, as pretty common. You wouldn't expect to go to Okeechobee and have an ocean view room, would you? But if you've never been to Okeechobee, okay. There are nonprofits that work with centers that can help provide things for indigent patients, such as clothing and necessities of life. Please just be sure to ask if this is the case. Do your due diligence. When it comes time to find treatment centers for your loved ones, please don't try to go at it alone. Don't be embarrassed or ashamed. You are taking the greatest and bravest step possible by seeking help. Don't let anyone tell you any different. Please reach out to one of us for help. Reach out to AA or NA. There are gentlemen here today from those programs, I believe, that can be of help to you if you're struggling. This is what we're all here for. Don't go through it alone. Your best shot for success is to want it more than anything and let people who truly care help you. Now I'd like to introduce Franny Watford, who's our Director of Nursing at Treasure Coast Community Health. And these are Steve's words, but I endorse them 100%. Franny is truly what a registered nurse was meant to be. She truly advocates for what's best for her patients and truly cares to see them get well. The floor is yours.
Thank you. What Vicki was talking about was very important. I actually have some personal experience in a not so upstanding facility that we sent a family member to, so those are very important questions to ask. Okay, so my name is Franny Watford. I'm a registered nurse and the Director of Nursing at Treasure Coast Community Health, and I'm going to talk to you today about medication-assisted treatments. Medication-assisted treatments are the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to treat substance use disorders and prevent opioid overdose. The medications work to normalize brain chemistry, block euphoric effects of opioids, relieve physiological cravings, and normalize body functions without the negative effects of the abused drugs. Medication-assisted therapy is given in a range of settings that includes hospitals, correctional facilities, offices, and remote clinics. The patients must receive counseling, which can include different forms of behavioral therapies. The ultimate goal of medication-assisted therapy is full recovery, which includes patients living an independent life. This treatment approach has been shown to improve patient survival, increase retention of treatment, decrease illicit opioid use or other criminal activity among people with substance use disorders, increase patients' ability to gain and maintain employment, improve birth outcomes among women who have substance abuse disorders and are pregnant. People may safely take these medications used for months, years, several years, or even a lifetime. Plans to stop a medication must always be a decision made between the patient and the medical or behavioral health provider. And then I want to go in and talk a little bit about the history of medication-assisted therapy. Like we heard earlier, opioid addiction really started after the Civil War. Opiates were, I found this very interesting, opiates were used to treat mostly upper to middle class white women for menstrual and menopausal symptoms, along with a group of people such as the Civil War veterans who also had medical procedures. By 1900, an estimated 300,000 people in the U.S. were addicted to opiates. In the 19th and 20th centuries, society was sympathetic to these people because mainly neither group presented a major social problem. In the 1920s, there was an increase in crime related to acquiring illicit opioids, and it was reported in cities throughout the country. In 1929, Congress appropriated funds to establish 2 treatment facilities in the United States, initially called narcotics farms. One was in Fort Worth, Texas. The other one was in Lexington, Kentucky. These institutions detoxed voluntary patients with opioid addictions, and they also served as hospitals for prison inmates that were addicted to opioids. The prescribed stay was about 6 months, although some patients, especially the prisoners, were there longer. They could stay up to 10 years. These hospitals offered social, medical, psychological, and psychiatric services in addition to detoxification, and they had low patient-to-staff ratios, which was 2-to-1. The atmosphere was described more as prison-like, and 2 major follow-up studies were done to show these programs to be a failure. The next major change in opioid addiction was during World War II. Many European immigrants moved into areas that had pre-existing abuse problems, and then they acquired the addiction. This led to a hardened attitude when it came to those with addiction disorders. In the 1960s, heroin use and related crimes among the middle class was again on the rise, especially in New York City. By the 1970s, the U.S. military involvement in Vietnam was also having an effect. This is when the New York Academy of Medicine recommended that clinics be established in affiliation with hospitals to dispense opioids in a controlled manner to patients with this addiction. The American Medical Association and also Kennedy administration's Advisory Commission on Narcotic and Drug Abuse advocated research projects to investigate the feasibility and effectiveness of dispensing opioids in opioid treatment programs. Then there was methadone. Methadone was used when shorter-acting opioids such as morphine were eliminated as options for maintenance therapies. Methadone appeared to be longer-acting and more effective when administered orally.
It was also selected on the basis of observations of its use in patients withdrawing from heroin and also as an analgesic. Today's medications that are commonly used are methadone, buprenorphine, and naltrexone, which are used to treat the opioid dependence and addiction. Methadone, it activates opioid receptors in the body. Methadone works by changing how the brain and nervous system respond to pain. It lessens the painful symptoms of opiate withdrawal and blocks the euphoric effects of the drug. Methadone is offered in pill form, liquid, and wafer forms and is taken once a day. Pain relief from a dose of methadone lasts about 4 to 8 hours. Buprenorphine, which is such as your Suboxone, Subutex, Buprenex, produces effects of euphoria. However, these effects are much weaker than those of the abused drug. It comes in a daily dissolving tablet, a cheek film, or even a 6-month implant under the skin. Buprenorphine's opioid effects increase with each dose until a moderate dose levels off, and even with further dose increases, you hit like a ceiling effect. That lowers the risks of misuse, dependency, and side effects. Then we get to naltrexone. That's what I'm actually very familiar with. Vivitrol. It's a non-addictive medication that actually binds to the receptors in the brain that blocks the euphoric and sedative effects of narcotics. Therefore, if a person relapses and uses the problem drug, because the naltrexone is sitting in the receptors, it does not allow the opioid to get into the receptors to produce the feelings of getting high. This comes in a daily pill or a monthly injection of every 28 days. Because of the effects of the patient not getting a high, it requires to give the patient a lot of education because of them not feeling the effects of the opioids, they are prone to overdose. So if they continue to take their hydrocodone or heroin and they're not feeling the high, then they could overdose. So it does come with a lot of education. However, withdrawal from opioids must be completed at least 7 to 10 days before you can give the injectable naltrexone. And we've had a lot of success with that, and I'm going to introduce a couple people that are going to give you some success stories. So I would like to introduce Margaret Mahone to come up here.
Okay. Hello, everybody. My name is Margaret Mahone. I have a sobriety date, which is October 1st of 2017. So God willing here, hopefully in less than 2 weeks, I'll have a year of continuous sobriety of absolutely no mind or mood altering substances in my system. My story begins, I'm originally from a small town right outside of Washington, D.C. I'm an adult child of 2 alcoholic parents. And what that meant for me growing up was just absolute complete dysfunction. Police were called a lot. There was a lot of physical abuse and a lot of emotional abuse. You know, in 4th grade when we had career day, I never raised my hand and said, you know, I want to be just like my parents. I want to be an alcoholic. You know, but here I am, and today I know what I'm up against. You know, I have a 2-year older sister who's here. I love you. And she is normal. You know, and I have a 2-year younger brother, and he is what I like to call a stay-at-home son. Which is, you know, again, something that's produced from, you know, growing up in an absolute dysfunctional family. You know, I took my first drink when I was 15 and, you know, absolutely hated the taste of alcohol, but loved the effect produced by that alcohol. You know, it changed how I felt inside, and that was something that I believe I was looking for my whole life. You know, my story goes a little bit further to where I got a little bit older and finally that, you know, emotional abuse and that physical abuse came to a head where, you know, my father physically assaulted me so bad that my lower vertebrae was snapped forward. You know, he was arrested, he pled guilty. But right then and there, that started my introduction to those paper prescriptions to where the doctors give you, because I needed surgery to put me back together. because of that one incident, it has led me to 8 major lumbar fusions where I have more screws and rods in my lower back than, you can possibly imagine. I'm lucky to be walking. So for me, drinking combined with the prescriptions, it absolutely accelerated my drinking. And with the prescriptions of the, I was being prescribed fentanyl and Oxycontin and everything absolutely under the sun. And that brought me to a level of when I couldn't get what I needed from the doctor, then obviously I turned to the streets. And because of the cost of the opioids were so high, there started the heroin. And, it was an absolute round-robin, vicious cycle for me. And last year, it absolutely brought me to my knees. My doctor's office was raided by the DEA. He's now in prison. He'll probably never see the light of day again. And that, self-employed, entrepreneur who was selling those dry goods to me is now behind bars as well. And, I got to a breaking point to where I couldn't stand to look at myself in the mirror anymore. That what we call in the 12-step program, that pitiful and incomprehensible demoralization just absolutely took a hold of me. And I couldn't believe what I had turned into. And so I booked a one-way ticket down here to Florida, not knowing anybody in the world. I have not gone to a rehab. I've not been in a sober house. But I locked myself in a hotel room for 2 weeks, which I don't suggest, and I detoxed. And let me tell you something, what I was seeing before I flew down here, I was seeing things that weren't there. I was saying things that weren't true. The police were involved quite a bit, and, it got to a point where they pulled an intervention. I was Baker acted, and, I was in that hospital, and I just remember being so ill over the side of the bed, just asking, just please, if there's something bigger than me out there, just please help me, because I don't know how to live. And I've tried death so many times, I didn't know what to do anymore. And I ended up down here in Florida, and a friend of mine from up north who is a very well-known member of Alcoholics Anonymous came down to check on me. And his second night here, he goes, Margaret, do you want to go to an AA meeting? And, my first reaction was, no, I don't want to go to an AA meeting, but I didn't want to be alone, and I just couldn't stand myself anymore, and I said yes. And from that night, this man introduced me to some people in Alcoholics Anonymous who then were familiar with the Substance Awareness Center in Vero Beach, and said, listen, Megan, we think you have some outside issues, depression and PTSD. Why don't we get you into the Substance Awareness Center? And so, I feel as if people come into treatment, kind of one of two ways, which is like a doctor's office. We're either referred in, whether it's through the courts, the police, our loved ones, or we're a walk-in. I, at that point, was a walk-in into, Alcoholics Anonymous and the Substance Awareness Center. And I sat down with a counselor, and this counselor, said, listen, we have an option for you, and that is Vivitrol. She said the 3 benefits of this Vivitrol injection is that it's once monthly, it's non-addictive, and there's no mind or mood altering effects to it. I mean, there's no street value to it. And so right then and there for me, I was sold on it. If it's going to help me stop wanting to put bad things in my system, heck yeah, sign me up. And so I did. And the injection wasn't very comfortable. But then again, I was smoking cigarettes at the time, and somebody said, well, look at the side effects to the cigarettes you're putting in your system. Like, I clearly have a thinking problem. And, it wasn't too long until, I was going to meetings in a 12-step program because, again, I'm an alcoholic and an addict. So I was seeking out those support groups. I was attending group therapy and individual therapy at the Substance Awareness Center. And I was also working very diligently with Terry, who's not here today, at TCCH. And I tell you what, that woman saved my life. I had a few choice words for her the first time we sat down. She asked me some pretty personal questions, and I, gave her a not so nice answer and said, what does that have to do with why I'm sitting here in front of you? And let me tell you something, that woman never gave up on me. She never frowned down upon me. And this has absolutely changed my life. So the resources that were laid out in front of me and suggested to me, I took every single one. Somebody also suggested, an intense outpatient program, the Counseling and Recovery Center for Women in Fort Pierce. And I said, absolutely. And so many people along the way have looked at me and said, why would you voluntarily do all this? And I said, well, I was voluntarily doing all these bad things to myself. Why can't I just take 10% of that energy, and I was chasing the drug and the drink, and just put 10% of that energy into saving my life? And let me tell you what, it's been unbelievable. So I can't thank, SAC and TCCH enough, and the Vivitrol. Like I said, for me, it's once a month. There's no street value to it for me, and it doesn't have any mind or mood altering effect to it. And every month when they ask me, how have your cravings been? I've been like, that I haven't had any. So, I'm really impressed, and I just can't thank you guys enough for asking me to be here today. That's all I got. And then next we're going to introduce Jared. I believe, is it Jared? Is he not here? Jared Stringer? Franny, do you want to come up? Okay. I will introduce Carrie with Substance Awareness Center.
Good afternoon. Wow, we've had some great speakers. Thank you. I really appreciated to hear your story. My name is Carrie Lester, and I'm a licensed mental health counselor and certified addiction professional. And I'm also the newly appointed executive director of the Substance Awareness Center of Indian River County, and I've been asked to speak to you today about prevention as it relates to this opiate epidemic. So I gave it some thought. We can really think of prevention on a continuum, and at the farthest end of that continuum, what we're really talking about is preventing harmful consequences of the opiate addiction, which is really death. And we've seen the data, we've seen the overdose rates, and the CDC's preliminary data on overdose in 2017 is up by 10%, and I think Chief Touchberry touched on, that's over 70,000 American lives dying of overdoses. And so on that far end of the continuum, we have some hope, and we have a tool to reverse overdoses, and that tool is called naloxone. And Chief Touchberry gave us some data on naloxone or Narcan-assisted calls and opiate reversals. And naloxone has no street value. It has no intoxicating effects. It just has the effect of saving lives. And so thanks to an initiative through the Department of Children and Families, and a local partnership, our agency and Bay Street Pharmacy, naloxone is available free of charge here in Indian River County to anyone who wants to get the training and carry a kit. And so we encourage you to get more information about that. We've also seen an increase in the number of first responders who are carrying naloxone and making a big difference in saving lives, and we're grateful to see that. And that's so important because at that moment of overdose, we have the opportunity to channel somebody from that harmful consequence prevention into treatment, which is really going to be our next step in that continuum, because the goal of treatment is relapse prevention. And we heard Franny talk about medication-assisted treatments that highly reduce relapse rates for people. They help people engage and retain in treatment at significant levels. And so we need to make the community aware of those medications and help them access those medications. And a partnership with the Substance Awareness Center and Treasure Coast Community Health allows people to access Vivitrol free of charge. Let me see what else we have. The Surgeon General has updated, there's an update to the Surgeon General's report that came out in 2016, and there's a little postcard that the Surgeon General's put out for people, and he calls for us to be prepared when it comes to overdoses and to have naloxone, to know how to use it, to be trained in it, and to have it widespread throughout our communities. Let me see, where else am I? We can also use peers in our treatment piece or in our prevention piece, and the peers have a powerful connection at engaging and retaining people in treatment. We have a small pilot program in the Indian River County Jail where we're using peers to talk to inmates to help engage them into treatment, recovery, and potentially medication-assisted treatment. And the goal there is to help to decrease their interface with the criminal justice system. And these tools that I've just discussed could be considered our prevention efforts for those who've developed a substance use disorder. But more importantly, we must work to prevent and protect the vulnerable brain from ever developing the substance use disorder. The President's Commission on Combating the Opiate Crisis determined that prevention has been underutilized, and that it's cost-effective, and that it must be made a priority. Unfortunately, in the midst of a crisis, prevention is the first place we cut and we overlook, and it comes with devastating consequences. There's an ever-growing body of research that tells us what works and what does not work in the name of prevention. However, we often underutilize this science in our programming and policy making. Prevention must start early, it must address risk and protective factors, and it must be rooted in science. The next step back on our continuum is what we would call indicated prevention, and we would target those prevention efforts towards youth who are starting to demonstrate risky behaviors or individuals who start to become symptomatic of the disorder but haven't developed the full-blown disorder yet. We can take a step back from indicated prevention and we can do selective prevention. We can look at groups who would be high risk at developing a substance use disorder and put prevention techniques there. And finally, on the furthest end of our continuum, we can do universal prevention. And universal prevention is everyone gets the intervention. It's kind of like a vaccine. And simply put, those three prevention levels, indicated, selected, and universal, what we're doing is we're reducing risk factors and we're increasing protective factors. Right here in Indian River County, the Substance Awareness Center offers a universal school-based prevention program. And we can address risk factors at the school level, the community level, the individual, the family level. And at the school level, right here in our Indian River County, we put an evidence-based life skills training program. Almost every 5th, 6th, 7th, and 8th grader receives over 38 weeks of science-based prevention curriculum. And that's pretty impressive to me. And what that translates to is that's over 5,000 students receiving that curriculum. We also realize that some kids need to be tutored, and they don't all get it universally. And our agency offers an indicated prevention program. And so for kids who are engaging in high-risk behaviors, we address the risk factors on the individual and the family level. We do smaller groups. We work with the individuals, we work with the families to reduce the risk factors and increase the protective factors around our youth. And here in Indian River County, we have a substance abuse prevention coalition called SAFER. And its goal is to address risk and protective factors at the community level. The body of literature on prevention shows that programs should be comprehensive, that the key is skill building and social connection. Prevention science tells us that prevention is not scare tactics, it's not drug education alone, it's not recovery speakers or one-time presentations, that it needs to be skill building. Those other interventions just simply don't work, and some have been shown to backfire, eliciting the very behavior we're trying to avoid. Research emphasizes the importance of collaborating with prevention experts when choosing and implementing prevention programming and policies in order to avoid causing more harm than good. Specific to the opiate crisis, the President's Commission identified the importance of conveying to parents their critical role in determining their children's use or non-use of drugs. The Commission also suggested we must show parents how to engage in the conversation about drugs, that parental knowledge is limited, and we must help parents. Research shows that youth substance use is 5 to 7 times lower when parents took a strong stance against use compared to peers whose parents were ambivalent. Surveys additionally show that parents do not believe it's necessary to limit their teens' access to prescription pain pills in the home, even though 50% of the youth who tell us they're using prescription pain pills say they got them for free from family or friends. In Indian River County, our Safer Coalition promotes several parent initiatives along these lines. The first is Talk They Hear You. It encourages parents and tells parents the importance of engaging in that conversation and offers tips. No One's House encourages parents to take that strong stand against alcohol use in their home or in anyone else's home. And the Florida Youth Substance Abuse Survey tells us that youth report the most common place for drinking is in their own home or in the home of a friend. The coalition promotes another campaign called Safer RX, educating the community on the importance of locking up prescription medication and safely disposing of unused medication. They even distribute doTERRA bags, which will safely neutralize unused medication, and they can be tossed right in the garbage in the local landfills. The Surgeon General's postcard calls for us to safely store and dispose of prescription medication. The Surgeon General and the President's Commission recommend that we advance the concepts of addiction as a treatable brain disease, as we've heard about today, and educate families on warning signs, and Patty did a wonderful job with that. The U.S. Department of Health and Human Services Spotlight on Opiates calls for a cultural shift in the way Americans talk about the opioid crisis. The President's Commission highlights mass media as the most commonly used form of primary prevention, but it does note that that's not always been effective. And so if we're going to use mass media, the Commission recommends that it must be credible, it must be evidence-based, and it's got to be grounded in behavioral science. We've learned time and time again that our prevention efforts must be data-driven, they must be carefully planned or they can backfire, and they must be comprehensive and should target vulnerable individuals. Prevention must start early and continue throughout the lifespan. We implement school-based prevention programs for early prevention. However, our primary care settings can be a critical component for our continuous efforts throughout the lifespan. And there's an SBIRT process. I believe TCCH does it. It's screening, brief intervention, and referral to treatment. We have a lot of strong prevention efforts in Indian River County, but to continue to keep our home paradise, we need your help because prevention is a partnership. So I encourage you to become involved in prevention efforts. Consider joining the coalition. Carry naloxone, advocate for science-based prevention efforts, and support your local agencies who are doing prevention here in our community. And the last thing I want to share is that the Surgeon General's postcard does call for us to do a few things. He calls for us to talk about it, to have the conversation about preventing drug misuse and overdose, and to be safe, that to take opioid medications as prescribed, to always store them in a secure place and dispose of unused medications properly. To understand pain. Treatments other than opioids are effective in managing pain, and many have less risk than harm. And to know addiction, because addiction is a chronic disease that changes the brain and alters decision making. With proper treatment and support, people do recover, and there is hope. Be prepared. Many opioid overdoses occur at home. Having naloxone could mean saving a life. Know where to get it and how to use it. I thank you for your time, your care, your concern for our community. On the resource table in the back, there's information about the Safer Coalition, and there's information about the Narcan kits, and my information will be posted on the website through Beth. Thank you.
Thank you, Carrie, and thank you to the other speakers. I do know that we are running up against time, but we do have 2 speakers remaining, so I ask that those of you who are available to stay, that would be great. If you are going to leave early, I do encourage you to at least grab this page on the back that is the resources that we've been talking about, and again, that will be available on the Chamber's website at the end. At this time, it's my honor to introduce our state representative for this area, District 54, Erin Goral, and she's going to talk to us about legislation that has been passed and is being considered at the state level. Thank you, Representative Goral.
Thank you for having me here today, and I want to say thank you to those of you who have gotten up and shared your very personal stories, to those of you that will continue to share those stories. It's through those stories that we touch other people in the community and let them know that this is really something that is impacting all of our families and all of the individuals that contribute to making this state a great place. Also to the committee that put this together, and for the courage to have this conversation, for the medium in which you're putting it out, for those people that can't be here today, who I know from the number of people that always tell me, oh, I saw you on TV at a meeting, or I saw this meeting, or there are so many people in our community that care about what's going on, can't always make it to events during the day, and when it's available on television, they watch, and they pay attention, and they use the same resources. So thank you for the courage to have the conversation and to put it out there. I very much appreciate being part of it. What Carrie just spoke about a little bit, she mentioned the President's Commission quite a few times, and we passed a bill this year on the state level called HB 21, and regardless of what Dr. Cordner likes to say about whack-a-mole, it is never my intention, nor that I believe of any of my colleagues, to play whack-a-mole. It does, however, happen because through policy, you are implementing new procedures to a large state, 20 million plus people, and there will be unintended consequences. And sometimes you're not able to see those consequences through the problem that's in front of you that you so desperately want to affect and impact. And so we did the President's Commission, the work that came out of that commission, the emergency order by Governor Scott to address this problem really provided quite a framework for what we did pass this year. I'm certain we'll be back. I'm certain we'll be back addressing the challenges that our providers have had, the challenges our families have had, the challenges our pharmacies have had, and just the whole network that comes together around these problems. Because it is an organic process, and when you implement something to this scale, you shouldn't just implement and walk away, because we know that the problem's not going to get better. And so I just wanted to touch on a few of the parts of the legislation and some of the appropriations that were attached to that. There are 24 states that have enacted laws limiting opioid prescriptions, and so that's why when we look at what's science-based, what's research-based, what makes a difference in our communities, deciding to limit the amount that can be prescribed at a time is something that has been proven to make a difference. And the CDC found that, I know the favorite entity of the day, I know, with all of the information that's been given to us, but they found that the number of days for which an initial prescription is written has a profound effect on the probability of long-term use by a patient. And so it's based on that research that the 3-day period was put in place. Some states have statutory limits that go all the way up to 14 days of those 24 states, so 3 is definitely on the lower end. A concern as a legislator looking at and not being a medical professional is, do you really tie the hands of a medical professional? Does a medical professional know better than someone with a law degree about what a patient might need? And of course the answer every day is yes. And so how is a doctor able to do their job and still take care of the patients, but also work together to address this problem was all certainly considered as we looked at this legislation. One of the other big components, and we've heard a little bit about it today, is the Prescription Drug Monitoring Program, so PDMP. And that is, it's known that when it's effective in reducing the opioid misuse and other related health conditions, when there's a mandatory consultation with that resource. And in the past, we have not had a mandatory consultation with that resource in the state of Florida. So we were able to get some numbers, and when it was, say, in December 2017, prior to the mandate, just 20.6% of the medical doctors licensed in this state, so that's 73,000 medical doctors that are licensed, just 20.6% had access to the PDMP. Today, a few months after implementation, we are up to 46.6% of doctors, of medical doctors, have access to the PDMP, are consulting it to see what the prescription history is of the patients that are in front of them. We all know knowledge is power. Most of the time, knowledge is power. When we can understand who the person is in front of us and what their history is, it allows us to interact with that person in a better way. And so just that alone, I think, shows that there has been a real increase in awareness among physicians and providers everywhere. We may never get to 100% because, as Dr. Cordner mentioned, there are physicians who say, I'm not going to prescribe at all. I don't want this to be part of my practice. And so therefore, they might not need to have access to the PDMP. But we know that that will make a difference in the long-term fight against this problem. Also, there's data sharing components to the bill that were put in place so that we are able to track progress and success. It's never right to enact legislation without being able to determine whether or not it's been effective. And so we needed to be able to share, of course, while maintaining the privacy and protections that patients deserve. And so there's a way to do that with just general information. Let me see if there's a few more. I know there were some things in the bill we needed to align the state's Controlled Substance Act with the federal schedules of controlled substances. I know those things seem minor, but when you move from state to state and you have a different set of rules around prescribing, around schedules, it can be very confusing from a law enforcement perspective, from a medical provider perspective. And so it was a real opportunity to clean those things up in the state's Controlled Substance Act. There were some changes too around criminal penalties. There's a third degree to a second degree felony in criminal penalties related to controlled substance prescribing. And so this would increase it to the healthcare practitioner if the prescription was medically unnecessary or a controlled substance in an amount not medically necessary. So there were some provisions put in place so that there's real consequences for those people that are abusing, for the occasional bad actor, because I have great faith in our medical providers in this state, but as in every profession, there is an occasional bad actor, and sometimes law enforcement needs the tool in order to be able to prosecute. Also, the tableting machines and encapsulating machines. Earlier we saw a slide of a pill press. There was, state law did not criminalize these machines before this law was passed. So now these machines have also been criminalized, and there are fines and penalties in place, third-degree felonies and second-degree felonies. So I know we're running short on time, so I wanted to touch briefly on some of the appropriations that were made. There was over $27 million in non-recurring funds from the Federal Grant Trust Fund to the Department of Children and Families for the state targeted response around the opioid crisis. So non-recurring funds, that's not something we can count on from year to year, but it's something that usually the federal government will make a commitment to a certain number of years for us to implement our own programs. And these are to increase access to treatment, to prevent opioid overdose related deaths through prevention, treatment, and recovery activities. And then we do move into some recurring funds that have not been here in the past. So over $14.5 million in recurring funds from general revenue. And with those recurring funds, it allows all of the providers that you have heard from and seen in this room who are fighting this fight, it allows them to plan. It allows them to plan differently and to plan for, have a kind of a long-term vision around how we are going to attack this epidemic in our community. And so those funds are for outreach, addiction treatment, community-based services. And so I think that that's a really important component. There's also the $5 million in recurring funds for the emergency opioid antagonists for distribution from emergency responders. So you heard about that, the naloxone. Well, I'll tell you that of the $5 million that was allocated, only 48 of the 128 agencies met the requirements to get that product from the state. What it does is it allows the state to really leverage the buying power at $5 million for this treatment, as opposed to each individual agency going out and trying to procure a treatment that can be very expensive. And so hopefully through educating our first responders and our agencies about what they need to be able to do, they basically basically there's two criteria so that we can track that these treatments are going to entities that are using them appropriately and are tracking the results of their use. And so hopefully because these are recurring dollars, it means that they will be there year over year. There won't be a fight over them, the same way that there can be with non-recurring dollars. And that means that all of our first responders in the agencies will likely look at whether or not they can comply with the two requirements to track the value of that in their communities. And the final, there's actually two more. The $6 million in recurring funds is for medication assisted treatment for individuals, and almost $1 million was allocated to fund the improvements needed to the PDMP so that all of these providers, it expanded access to this resource that can help medical providers talk to other medical providers, and that is so important in this fight. And so I thank all of you. I know I don't have the most exciting part of the day, but I will tell you these stories. I've heard the stories that have been told in this room today, not from those of you that told them, but people come to see me regularly as a member of this community, now as a state legislator, and they share stories that are tragic. And I think that it's so important that we realize that it is a problem that can affect any one of us at any time, and because of that, we need to fight together. And so I thank all of you for being here. For those of you that are watching, if our office can ever help connect you to a resource as well, 140,000 people, some days we can be the personal assistant too. I think there's a lot of people that play that role in this room. We want to help get you to the right place, and that's what's wonderful about the people that came up here today. They are all partners, and what I do every day, I went to high school with Franny. And that's what's wonderful about Indian River County. And so I think that we can keep it that way, and we can keep working together. And thank you for your interest and your attention. It's very encouraging to see everything. So.
Thank you, Representative Grau, for explaining to us how the state is working to help correct the problem. And it's great to hear that the law wasn't only just around the prescribing, but there really have been very real dollars allocated towards some solutions with the Narcan, with the mental health initiatives. So I hope that many people have heard some things today that do indeed give them hope and help them realize that there are solutions available. And we hope that as a committee we've been able to put a lot of that together that makes it a lot more at your fingertips. That was really our goal. Our final speaker for today is going to be a person who is in recovery. His name is Keith Adams, and I'm going to call him up. And I'm at the conclusion. Shelley will be coming up at the end to do the conclusion. So I just thank you again for your attendance. I'm really overwhelmed and heartened by the fact that so many people in this community are here and have cared so much about this summit today, and just for the excellent speakers. So Keith, please go ahead and come up. Thank you.
First off, Teresa, thank you, and everyone who put this together. This is a great event, and just for myself, I can say how much knowledge I gained from this. Again, my name is Keith Adams, and my sobriety date is August 10th, 2016. I can just... Thank you. So I just celebrated 2 years of continuous sobriety, and I did that because I took suggestions, and I never did that before in my life. What I really want to touch on today is that for me personally, my addiction is more about my actions. I too come from a household where both my parents struggled with alcoholism, whether that was drugs or alcohol. But I made my own choices. I can tell you that today. That everything I did in my life, I did on my own will. So that's why I like to touch on what I did in my addiction was my own will, and what I did in my sobriety is the opposite. because I had to realize that my way didn't work, and I needed to try something else. And that started with taking a suggestion from my dad to come to treatment. And he told me in my driveway a little over 2 years ago that I never had to feel this way again. I know that's a big slogan that a lot of us hear in, in treatment and recovery and things like that. And the day he told me, I never heard that before. Now I heard it so many times, and I'm sure the people who continuously relapse, they hear it all the time. But I took that and never had to feel that way again. Through the grace of God, I never picked up a drink or drug when I wanted to stop. And I can attribute that to taking suggestions, like I said, not doing things my way. And what I had to turn my way into was a higher power. And for me, that's God. And that's where it had to start for me, because I left God out for such a long time. And I had to be taught that it wasn't religion, it was more of a spirituality thing. And that's really a touch on that, but I just know that turning over to a higher power, my resources came unlimited. When I leave it to myself, there's only so much I can do. And I had to realize that God can do for me what I can't do for myself. But, when I came down here, like I said, I didn't know anything about treatment. I didn't know anything about a program. I didn't know really anything about recovery. The only thing I knew about was how to get myself into trouble and try to lie, manipulate, steal my way out of it. And I just had to try a new way of life. So, like I said, I came down here a little over 2 years ago, and I went to a treatment center called Dynamic Life Recovery, which is in Indian River County. It is no longer a treatment facility. It's just a sober living program, which I am the manager of today. We're a sober living program. We're not on the resource list because I didn't get the information over to Teresa in time, but she said she's going to update on the resource list. When that's something I always did. I have no use of time, and I'm always late. But like I said, I came down to Dynamic Life, and I just went through treatment just like everybody else. And I didn't do things perfectly in the program. I didn't do everything they told me to do. But, I listened and paid attention. I couldn't tell you when I went through there if I was going to, use opiates again. I didn't know. I just knew that I was in a better place than I was before I got down here, and my life slowly started getting better. And I can tell you that Alcoholics Anonymous has worked for me. I can't tell you that every person who enters a program, it's going to work for them. Now, I'm not knocking NA, CA, a recovery church, whatever it might be. What I'm just saying is you should find a program and get a sponsor or a mentor. In my experience down here, that's what I see people have success doing. So that's what I did. I went to the treatment center. They gave me the resources I needed to continue my sobriety. And then when I got out, I lived on some guy's couch. I didn't get into a halfway house. I didn't, have family down here. I just did what I could do. And I humbled myself. I can tell you that money to me is a huge addiction. And I thought you needed to make $30 an hour, to live. So what I was told to do was do the uncomfortable, and things that I wasn't used to. So I got a dog I got a job at a dog grooming salon. I hate dogs. Can't stand dogs. Don't like them. I can tell you, I only took the job because somebody told me that it was a pretty female who owned the company, and I'd be paid $12 an hour. That's what I was told. So I went, and one part of that was true. She was a pretty female, but I started out at $8 an hour. And I joke around my sponsor all the time. I called him and said, I'm leaving today, now. I might not make it till lunch. But what happened in the afternoon was that she showed me what I'd be doing, and that would be, excuse me if I want to gross some people out, I'd be cleaning the dog's anal glands. That's what I had to do, and I saw it, I'm wearing an apron, and I just thought, this is not where I should be. This is not what I signed up for. I'm leaving at the end of the day. But I didn't. I stayed that day, and it was funny because later on they told me they had bets whether I'd not come in the next day. But I did because I knew at that moment this is happening for a reason. I'm not a big believer in coincidences today, but God was aligning me for what I had to go through, and I continued with that job for 4 months. Not every day was great, but I still have a license today. I drove 4 miles on a bike every day to that job. At 7 o'clock in the morning. And the amount of humility, not to be, not humiliation, but humility that I learned from that job was things I never had before. I needed to work for minimum wage. That's something I had to go through. I needed to realize that it wasn't the amount of money that my problem was, is how I handled the money and how I just threw it away my whole entire life. So just things that I had to go through. So like I said, now I manage a sober living facility, and I talk to guys' parents at all-male facility. I talk to guys' parents all the time, and they're always asking me, what's the percentage rate? What's the percentage rate? And I tell them 100%. They said, what? I said, yeah, 100%. They said, oh, if my son goes there, you never have guys that relapse? I said, no, we have guys that relapse, but the program works 100%. You know, the program that we put out there, all these facilities, all these resources that we have, they work. It's whether you're willing not to do the work. That's really what it comes down to. You know, there's a reason why people recover. You know, in the literature that I went through, it talks about recovery more than it does alcohol or drugs, you know, because we recover. That's what these programs are designed to do. Now, I'm not here to say that everyone's going to, you know, recover from their disease. You know, they're not going to. But if you do what the people before you have done, and if you get a sponsor, you get a mentor, and you're willing to take their suggestions, you have every resource to recover. You know, and that's what we're here to do. Megan, who spoke earlier, I've actually, you know, got to know him pretty well, and, you know, I was told through my journey that you would see people come through that, you know, you benefit from what they do. And she said, by the grace of God, she'll have a year sober here in a few months, and I've got to watch that. So I get to watch people come in, do the right thing, and get sobriety time and get their life back together. And that's what makes me want to get 3 years, 4 years, 5 years. I remember in the beginning, when I went to meetings and stuff, I wouldn't pick up chips for my month or 2 months, 3 months. I didn't pick up any chips. So when it was almost time for my year anniversary, my sponsor said, he mentioned something about it, and I said, oh, that'll be the first chip I ever picked up, I think, ever besides my white chip. And he said, what do you mean? And I said, well, I told you in the beginning I wasn't down here for a month, 2 months, 3 months. That wasn't my goal. You know, my goal was to get a life back and, you know, and get endless amounts of sobriety. I'm very competitive. I probably wanted 100 years or something is probably what I said. And he said, like, have you learned nothing? He said, that selfishness that we talked about, you still have that? You still think it's for you. You still think that people get chips to, you know, get their sobriety time is about you. It's not about you. It's about the guy there who has 1 day to see that you can get 30 days. For the person who has 30 days, you can get 6 months. Person who has 6 months, you can get 2 years. You know, it smacked me in the face. I don't know, you know, I really haven't learned anything. But that's what it's about. But you always have to be growing, too. If I'm not growing in my sobriety, I'm staying stagnant. If I stay stagnant, I'm eventually going to go backwards. But, you know, I'm just grateful for that. I'm grateful to be able to take suggestions. You know, also a word that I learned about was vulnerability. Prior to coming down here, I would have told you vulnerability was a weakness. Today, vulnerability is a strength. It has to be. Because if you're struggling and you can't go to someone and tell someone you're struggling, how can they help you? Everyone today talked about resources and how they've overcome things. If you can't admit to someone that you're struggling, you never have a chance to get well, because no one's going to know what you're going through. And it's sad when you hear about parents talk about it. I didn't know my son was going through this. You hear significant others, oh, I didn't know. It's because we're really good at denial. I can say that before I got down here, no one in my family knew what I was going through. Not one person. The only people who knew were the people I was getting the drugs from. You know, I would have loved to gone through the surgeries that, you know, Megan went through to get prescription pills. I didn't have that. You know, I had to go spend $150, $200 every single day to fulfill my needs. You know, and I was I had so much pride. I couldn't even get it from a drug dealer. That's how much denial I was in. I had to get my younger cousin, who I would supply a pill to get it for me, because I'd be darned if someone knew that I was doing what I was doing every day, because I had so much denial, so much guilt. And that was through coming down here and getting sober to know that until I can look somebody in the eye and tell them what I've gone through and what I'm struggling with, I have absolutely no chance to recover. So whatever I was up against before, whatever I was so embarrassed about, it had to become an asset. It has to be. Because I'd be able to look back at that and remember what it felt like to never want to go back there again. When I got down here, I can remember I couldn't look in the shower, and I watched this movie called Unguarded. It was about this guy who played in the NBA, and he said that, you know, he couldn't look in the shower, he couldn't look in the mirror when he shaved. I think I said that wrong. I couldn't look in the mirror when I shaved because I was so embarrassed. I had to shave in the shower. And I remember being in treatment and being able to look into the mirror and shave every day. And there were like little things that I can remember. And I can tell you firsthand that I have not done everything perfect in sobriety. I've had quite the struggles along the way. My mother just passed away this past year, right around Christmas time, and that was probably is the hardest thing I ever had to go through. But I didn't have to pick up a drink or a drug because of that, because there is a solution, and that's what we're actually talking about here today is a solution. There's nothing today that's going to come into my life that drinks or drugs has to be the outcome. It doesn't have to be. You have a program, you have a network, you have a support group. That's vital. You have to have people that you can go to, because like I said, I wasn't able to go to people before and tell them about my strengths, or I'm sorry, I could tell you about my strengths. I couldn't tell you about my weaknesses because I wasn't vulnerable enough. I had false pride. I had a false ego. There are things that I had to get rid of. But like I said, you're able to overcome all them things, and then you have to help others. That's why we're all here today. We're all here today to help other people. Unless I was getting paid, unless I was getting something on the back end, unless I was using you in some way, I would never help you prior to getting sober, because I didn't understand the point. I remember my sponsor came in, and he would meet with me during the week at my program facility. And I went to my therapist the next day, and I said, "What, does that guy Gene, is he on the payroll? Why does he come and help me? I don't understand. Why would he do that?" And my therapist started laughing. He told me to keep going to meetings, and then you realize what helping others does for you. And that now, being in my position, it's hard, watching guys come in and their life starts getting better and they have so much potential, and then they fall off, and you have to get the phone calls from the parents, and you go through it with them, you get them back into detox, and it's not always pretty. But then there's the guys who come in and they do the work. They come in, they hit the ground running, and and they're willing to do anything, and it's awesome to see. And I'm just one guy in my mind now who came down, and he didn't know whether or not he wanted to get sober. He just knew that this was better than where he was, and he took every suggestion, give it to him. He started working a program. He got a relationship with the Lord. He took a job that he wasn't accustomed to, and now I think he has 4 months of sobriety. And his aunt's calling me every other day, thanking me, and I told her, you don't need to thank me. I'm just here doing what other people did for me, and that's how this whole program works. It's just by helping other people. So I hope I've touched one person here today, and Teresa, thank you again. Thank you.
Thank you so much, Keith. So we're coming to a close of our program, which I have been so very excited about. I couldn't wait for this to happen today. We have all of our Health and Wellness Committee members from the Chamber of Commerce have just come together and pulled all the resources and done everything that they could and worked hard to get this symposium together. And I have to just throw a little personal thing onto this. This just feels like a dream to me. I am the mother of an addict, and he struggled for 17 years. He didn't just struggle, he did struggle, I will tell you that. Don't let anybody say an addict is just getting away with, irresponsibility or whatever. They struggle, they suffer. But so does the family. And I have seen so many everything that you want to talk about that an addict might do, I will tell you that I've been through it myself, because whether you want to or you don't, you walk alongside your children. And you can look at them and you can say, okay, it's time for you to go off and get this taken care of, and goodbye, do the best you can. I don't think many mothers are very, very good at that. I think that we still walk beside our children. So going to anywhere from the lying, the stealing, going to bail somebody out of jail, sitting in court, going to centers to hopefully help my son. Ending up in the middle of arguments within his family and watching children suffer, my grandchildren suffer. It's a horrendous thing for a family to have to go through. And then I speak to you because if any of you are going through that, if any of you are going through it, and I know that there's people all over in this county, all over the United States, come together. I didn't talk about it for a long, long time. And I felt that it was my fault. Maybe some of you have felt that same way. And it's very distressful. Let's talk about it. That's why I'm so thrilled about this, because talking about this kind of a problem takes the mystery out of what it is that's going on with people who are going through addictions and what families have gone through. And maybe you won't look at your neighbor and go, oh, they just must have had a really bad life because that son, is out and just getting high all the time. And there's just a lot of negative attachments to this disease. So I don't want to go on and on, but what I do want to do is I just want to say a prayer for each and every person in this room who is addicted, who's fighting addiction, who's the mother, the sister, the brother, the aunt, the uncle of an addict. And I pray that you will find the strength and that you will find, that you will turn to God and that He will help you through the difficult times that you're going to go through, and that you depend upon your friends. The gentleman that just spoke, he said, this is about depending upon other people to help us through things. So let's depend on each other. We don't need to keep this secret. It's not your fault. Their actions aren't their faults after they've become addicted to the drugs. So thank you all for coming here today. Congratulations to you for wanting to learn and to be a part of the solution. Give yourself a big applause. Thank you. And there's snacks out in the other room. Please take some because there's lots left. And drinks.